Do what?
We're getting started.
Oh, so we're moving from here. Okay, y'all just gonna have to remember everything. Okay, let's look at the A and P part of this real quick. This is stuff hopefully you already know. You had this in, was it ninth grade? Who can remember ninth grade?
Some parts.
Seventh grade had seventh and ninth grade?
I had no history.
Biology? Okay. Well, anyway, the important things I want you to know are probably these four little things here. Which ones are the ovaries? This? This?
No.
This? How many we got? Okay. And what happens up here? The eggs develop and they're passed down these, what do we call these little tubes? The fallopian tubes. And then what happens? No. Hopefully, for what we're doing, it implants here, the endometrium level. What do we call this organ right here? The uterus, that's right. What is this little thing right through here? The cervix. And what does that do? Keeps everything from falling out, pretty much. Okay, that's going to be the opening here, the vaginal opening. And what else do we need to know here? I think I have some more stuff on the Yep. Okay, so you need to know about the ovaries. They're going to secrete the estrogen and the progesterone that allows for the development of the egg and allows for the implantation into the uterus. Mature egg is often called the ovum. And the hormones will then prepare the lining of the uterus to accept that. And this is a monthly thing. This is the whole menstrual flow thing. The body gets ready for the implantation of the egg like it's coming. And then if it doesn't get fertilized, it says, oh, false alarm. So everything sloughs off and leaves. But if the egg's fertilized, then everything is ready in there for the implantation. So that's all. That's the good stuff. The fallopian tubes, it's going to be the passageway that the egg moves along that transports the egg down to the uterus. And that is a very vulnerable time for the egg, in that if it accidentally gets fertilized before it's gotten down to the uterus, then it may actually implant and start growing inside the fallopian tubes, which is not a good thing because they're very small little things. I told you that.
Is that very common?
It's more common than you would think.
What do they do about that?
Well, hopefully they're going to catch it. They're going to have to remove that fertilized egg.
So it's a goner?
That's a goner. Yeah. It can't develop there. It's got to be inside the uterus to have a successful pregnancy. Let's see. So you got two fallopian tubes. I already told you that. That ovum is moved down through the fallopian tubes through a process called peristalsis. Where else have you heard peristalsis? Where else do we have that? Do what? The digestive system, certainly. When we swallow, all that's peristalsis. It kind of moves it along. So that's what's happening there into the uterus. I just put that word so you are familiar with it in case you see it on National Registry. Okay, y'all ready? I wonder, is this going to be about something upcoming or is this about something I just told you? Let's see. Which of these contracts to the size of a grapefruit after delivery? 3 more. 2, 1. Bingo. What do you think it is? Whoa. Okay, answer is the uterus. And we're going to talk about that whole process as we move through here. But yeah, after delivery, that uterus hopefully is going to start shrinking back to its normal size. Normally it's quite small because it doesn't really do much of anything except when it's maturing the ovum. Okay, the uterus is a pear-shaped organ, and that's where the fetus actually develops. That's its little home for how long? About 9 months, yeah. And the nice thing about that organ is it'll expand as the baby expands. It's kind of like, you know, a shell of an egg, I guess. Is that what happens with chicken eggs? They start small and get bigger?
No.
Who's ever thought about it? No, they don't. They just come out like that, don't they?
My mama has a little chicken running around with her mom.
Yeah?
She
How
likes
cute.
chicken.
Okay, so anyway, it's going to enlarge to accommodate the baby. And then it also is very muscular, and it protects our baby. And it allows for forcible contractions during labor and delivery. So it is a little workhorse during reproduction. After delivery, the uterus rapidly contracts. It's going to shrink. And it's been so busy, you recognize that it's a very vascular organ at this point. You know, it's something that bleeds every month anyway for anybody that has one of those. And so it's very vascular. So one of the things it's doing after delivery, it's got to start tamping off all those blood vessels that the baby was using. You know, it's got to fix that little connecting area where the baby's been attached to it. So it's got a lot of stuff to do there. Okay, the cervix is going to be the opening at the bottom of the lost my train of thought here. At the bottom of the uterus to the opening of the vagina. And a mucus plug is going to form there, and it keeps that area soft, it keeps it moist, and it's like a little plug, like if you put a stopper in a bottle or something, it acts like a stopper. And it's going to come out shortly before the baby is delivered. The cervix is going to be we talked about what the cervix was right there at the opening of the vagina, but what it does, it stays very close and tight along with the mucus plug there to keep anything from falling out. But when it's time for the baby to fall out, the baby to come out, it's going to what we call efface. It's going to get very thin, and it's also going to dilate. So the thinning is just as important as the dilation. That's going to allow it to open, to allow the baby to pass through. So effacement is very important. Now we as pre-hospital providers are never going to examine a female and see how dilated she is or how effaced she is. We're going to look if the baby's crowning, and you'll be able to see the baby's head there. But that will indicate that she is dilated and effaced, but we're not checking specifically for that. You've heard a woman say, or somebody say, they pass their mucus plug or a bloody show or something like that. Sounds really nasty, doesn't it? But that mucus plug that's been right there at the cervix will be passed shortly before delivery, and it may look like bleeding. That will pass oftentimes right when the water breaks. You've heard.
It's not the same as the water breaking?
No. You can lose your mucus plug before your water breaks. The water is going to be the sac that the baby's in. Usually they happen in pretty close proximity, but they don't necessarily go together. Okay, we talked briefly about the reproductive cycle. It's usually 24 to, we got 35 days there. The body's getting ready every month for implantation of the fertilized egg. If that doesn't occur, then all that preparation is gone to waste. It's like you had a party, nobody came, you got to tear down all the streamers and throw away the party plates. So everything leaves. So certain things happen getting ready for that pregnancy. The wall of the uterus thickens up, it becomes more vascular, the ovum is released. If it's not fertilized, it's going to go ahead and leave. And all of that, the lining of the uterine wall, that vascularization that's occurred, will be sloughed off and be expelled. That usually takes 3 to 5 days. So nothing here that you guys are not familiar with, I think.
Just to be clear, is the best time for a female to get pregnant right before she would have her period?
No, actually it occurs once the egg is released and it starts moving down. It's usually in that midway period, like in the course of, if you've just finished your period, it's probably going to be about 10 to 12 days after that point. It's going to be your most fertile time. Fertilization is fertilized by the sperm. The ovum, once it's been fertilized, it really becomes an embryo now. It's just the very beginning of the baby. And so the stages of pregnancy begin here. Any questions about that? Y'all make sure you go back and read that. I know you've had it several times before. If there's any part of that you don't understand, let me know. We can go into it, but it should be covered pretty well in your book too. Let's look at the physiological changes in pregnancy, because this is where you're going to be encountering the pregnant woman who has some type of complaint. it may or may not be associated with her pregnancy. You know, you can have a heart attack when you're running a marathon. You can have a heart attack when you're watching TV. You can have a heart attack when you're pregnant. So just because you're pregnant doesn't mean everything that happens to you is related to that pregnancy. So you need to be able to recognize the physiological changes that occur during pregnancy so you can separate what's due to the pregnancy and what's not. Okay, changing the reproductive system. In order to understand the whole, what's going on physiologically, you need to understand how all of this occurs. This is just anatomy and physiology here, except you need to know some of these parts. This big blue thing right here is what? That's going to be the placenta, and that really is the organ that provides nutrition and oxygen and blood flow to the baby. And it's going to be attached by what? The umbilical cord. And all of this then is attached to what? Yeah, right here is the amniotic sac, and it's going to be attached right here in the wall of the uterus. So you're going to get blood flow from the mom to the baby, oxygen flow this way, and back and forth. Now there's not a direct connection here. You don't have direct circulatory flow from the mom to the baby. It's all fed through this organ and then to the baby. So there's no direct flow, and not everything that goes into the mom goes into the baby. A lot of it does, most of it does, but not all of it. We've got all of these parts. The fundus, I don't see it on there. The fundus is going to be the top part of the uterus. So if you got a woman that's big and pregnant, this top part right here is going to be the fundus. And then wherever this is attached, wherever your placenta is attached, it could be anywhere, but it's usually going to be on one of these sides or up at the top here. We like it up at the top. Could attach on the side, but we'll talk about some more of this a little bit later. Okay, y'all ready? Everybody wake up so you can vote. The organ that provides oxygen and nutrients to the fetus. This will be organ is the operative word here. All right, let's see. Okay. The organ actually is the placenta that transfers all that. Remember I just showed you that just a second ago? Remember? Back up. Remember I said this is the placenta, that's the organ that provides this. All right. The umbilical cord is the conduit through which it goes, but the placenta is the organ that manages all of that, provides it. Okay, fetal development organs, the placenta, we just mentioned that. That's, the placenta develops as the ovum attaches inside the uterus. So it's going to develop so that it can provide the nutrient and the oxygen and everything to the baby. It's going to be the baby's not breathing like we breathe and we exhale carbon dioxide. We give off other waste products that way. We pass other waste products through the gastrointestinal system, the urinary system. Well, all that is going to be done for the baby in utero. So any urine, fecal matter, any waste products, all that's going to have to move back through the vascular system and then through the mom's system for exchange. The blood of the fetus and the mother do not mix. This is how you can have mothers with different blood types than the baby. Everything is transferred through the placenta. Okay. The umbilical cord, everybody knows about the umbilical cord, right? Okay. Where does it attach? The belly button, the navel. Yeah. In the umbilical cord, we're going to have one vein and two arteries. And this is the only other time where you've got arteries and veins that are doing opposite from what we normally think of. What do we say about arteries and veins? Most arteries carry oxygenated blood, right? Okay. In this case, it's going to be the opposite. So you've got one vein and two arteries. Veins carry oxygenated blood and nutrients to the fetus, and the arteries carry deoxygenated blood and waste back to the placenta. So it's opposite to what happens in the mom. That's one of those little memory things you're just going to have to remember. So when's the other time where veins carry oxygenated blood? In the lungs, right? Pulmonary arteries. Y'all okay with that? Good. All right. You think she's going to ask us that question?
Probably.
Nope. What is the volume of the fluid in the amniotic sac? I'm doing some guessing here, huh? One more. One more. Okay.
The book says.
Pretty much all over, huh? Okay, what do we bet that the most votes, 38% is right? What do you think? Ta-da! Now see, this is partially my fault. I told you guys we were doing pediatrics tonight. Now I know y'all all went back last night and read chapter 35 instead of 34, right? Not. Do what? I didn't know. I was asking you guys. Okay. The amniotic sac has about half to 1 liter of fluid in there. Baby floats around in it, gets massaged by it, kind of protects it, insulates. So amniotic fluid is a good deal for the baby. Kind of needs that. Cushions everything. Love to float around. It allows that baby to move around, which is good. It don't want to get stagnated. All right, I told you the lower part of the birth canal is the vagina. Now, one thing that happens, I mentioned to you that the cervix is going to efface and dilate. Well, the vagina has to dilate also. It has to be flexible enough for that baby to pass through there. And it also has some peristaltic action there because hopefully that baby's sliding on forth at that point, but it's got to have a little bit of muscular contraction in order to move that baby on down. Okay, how does the development of the fetus affect other body systems? This is really what we're going to go into now because this is important. It really affects almost all the other body systems. So the reproductive system, we've kind of been through there. With the development of the uterus, as it's ready for the implantation and as it holds the baby and provides nutrients for the baby, it's going to have about 1/6 of the circulating blood volume of the mom is going to be contained in that one organ. So it's very vascular. So the mom's going to have to up her total blood volume in order to accommodate the baby. So she's going to have an increase in her circulating blood volume. Respiratory system. Okay, the mom is going to have an increased demand on her system for oxygen. So it's going to be an increase of about 20%. Some of the other changes that you're going to see, the respiratory tract, the resistance in the respiratory tract is going to decrease. That means she's going to have bronchial dilation. They're going to be expanded or relaxed, if you will, so that she can more easily move higher volumes of air in and out of her respiratory tract. Her tidal volume increases by 40%. What exactly is that? Yeah, she's going to take more air actually into her lungs, 40% more. So she's going to breathe deeper. She's working harder because she's providing oxygen for 2 people instead of just 1. So her respiratory rate, is it going to increase or decrease?
Increase.
Yeah, she's going to breathe a little bit faster. She's going to breathe a little bit deeper. Oh, y'all ready? Okay, good. Normal heart rate during pregnancy? Now notice we got 2 different things. We got percentage or beats per minute. So we have to select. You can change your answer too if you want.
We change it after you tell us what the answer is.
No. We got 13? All right, let's see. Boy, 25% is a lot. Okay, answer is, ta-da!
Yes.
It's really beats per minute. So whatever's normal for them, it's going to be kicked up. So if they're normally 68, it would not be unusual for them to be at 80. If they're normally 80, then 92. So it's not really a percentage. It just goes up by a little bit. But you need to recognize that because why? Yeah, you don't want to automatically assume that she's shocky because she appears to be tachycardic. But if she's got a pulse rate of 128, is she tachycardic? Yeah, she's tachycardic because she wouldn't have a normal heart rate of 110, would she? Probably not. She shouldn't have. So they're not going to be grossly tachycardic, but expect their heart rate to be up a little bit. Okay, cardiovascular system. Their cardiac output is going to increase. What is the cardiac output? And it's a function of what? Huh? Well, the heart. It's going to be rate, how fast it's going, and stroke volume, how much volume it's putting out. It's going to give you your cardiac output. So that she's a little bit tachycardic, but her contractions in her heart are going to be a little bit more forceful. It's going to be pumping out more blood. It's going to be circulating more blood because how much more blood volume does she have? Remember that? 20%, close to 20, 18, 20% more. So she's circulating that increased blood volume, so her cardiac output's going to increase. The blood volume increases by about 45%. So she's got a lot of extra blood volume, and it's doing a lot of work. What's that extra blood doing? It's transporting oxygen and waste products from the baby as well as herself. So the baby is going to increase, but part of that's going to be her own increase from working with the baby. Maternal heart rate increases 10 to 15 beats per minute. The blood pressure decreases slightly during the first couple of trimesters. Just because a woman's pregnant later in pregnancy, she shouldn't have increased blood pressure. If her blood pressure is going up, she's got a problem. So it should not be. She should have normal blood pressure during pregnancy. Early on, though, it may drop a little bit. So is that important for you? Not really. But it is important that later in pregnancy that you recognize that she should have a normal blood pressure. Just because she's pregnant, that doesn't give her a pass to have a higher blood pressure. So another important change cardiovascular-wise is their clotting increases. As the pregnancy moves along, their clotting factors increase quite a bit. And any idea why that occurs? Yeah, so they don't bleed out during delivery. And if there are any insults along the way, we don't want her to bleed out. So clotting increases for a reason, but what complications can that bring? Yeah, she gets much higher risk of blood clots because of that. Okay, gastrointestinal system. What happens in the gastrointestinal system of a pregnant woman? Huh? Yeah. Nothing works really good there, particularly as you get late in pregnancy. Things slow down significantly because the baby's sitting on top of everything. Nausea and vomiting early in pregnancy is much more common. You know, there's so many things going on. The body's saying, I don't have time to worry about you, gastrointestinal system. I'm worried about increasing my blood flow. Got so many other things to do. So nausea and vomiting is very important. You'll see it commonly in the first trimester. Decreased motility. What does that mean? Yeah, nothing's moving too good. So constipation during pregnancy is not unusual. They often feel bloated because they are. Things are backing up in there. Urinary system. Renal blood flow increases because renal blood flow. Blood flow through the kidneys increases. A lot more waste products. You know, that baby's putting out a lot of waste products. She's putting out more waste products. So you're getting a lot more blood flow, a lot more pressure on the kidneys to do their work. The bladder is moved out of the way or just plain sat upon. What's going to be the impact there? Yeah, it can't really expand quite like it should. It can't hold the volume that it needs to hold because somebody's sitting on it all the time. So they urinate a lot. However much you think you go now, if you're pregnant, you go all the time. Also, in pregnancy, there's an increased risk of injury as all the organs are moved around. They're not in their safe little habitats anymore. So you have an increased risk of injury, therefore. Increasing, I already said that one. Musculoskeletal system. It's interesting how the body is prepared for all this transition. What do you think is happening with the musculoskeletal system?
It's got a stretch.
All right, your skin stretches. What else? Your muscles stretch, so they become more compliant. Do y'all like the way I use that word? Not so much.
No.
Compliant, you know. They stretch normally because somebody's pushing on them. That's compliant. What else happens?
Do the hips sit out a little bit more?
The what?
Do the hips sit out a little bit more? I know they're already a little bit more.
Yeah, they're already shaped differently for that purpose. But yeah, the muscles around them, which hold them taut, relax a little bit so they can move. So the joints relax. The muscular system all over the body becomes more relaxed. It's almost like, you know, anybody that's double jointed? You know, it's like, oh, how do you do that? Well, the female, with that relaxation of the muscular system, allows more joint movement throughout the body, not just at the hips. So can you see that could be a problem? Yeah, if you think about them being very large and pregnant and they've got an extra 30 or 40 pounds hanging in front of them like this, and now their joints are looser because their muscular system is looser, can that be a problem? Yeah. What's that going to do to, like, their chances of falling? Yeah, greatly increase their chances of falling. So the pelvic joints loosen because of the hormonal changes that allow the muscles to relax. If she's very pregnant, very far along, then she's going to lose her center of gravity is going to be lower, more like guys have normally, I guess, which can throw them off balance. Think about the other issues. You know, she's got this big old belly here, you know. Is there a sight issue here?
Yeah.
Yeah, I can't see where I'm going. I can't see if, you know, little Johnny's left little toys on the floor. So greatly increases their chances of trauma. Because of all this weight on the front and then the loosening up of all the joints and the muscular tissue, then they may have back pain. You know, it's carrying that big old load and you don't quite have the stability, so you see back pain very frequently. Okay, questions about that? Those are going to be some of the changes in the body systems that you'll see. And those things are going to impact the mother greatly. So when you're doing your assessments on your patient, you got to factor in all those changes as pertinent to your assessment. Okay, labor and delivery. What time is it? Yeah, y'all want to take a short break at 6 o'clock. Y'all run out for 5 or 6 minutes. Whenever you get back, we'll start back. Hang on just a second. Let me stop this. So, labor and delivery. Let's get after it, guys. For your favorite time. Okay, we kind of looked at all of this stuff. I don't think there's anything new here, but just look at the way everything lays. You can see that right here is the vaginal, the birth canal, where the baby's going to come. This is the rectum back here. So I will caution you, if you ever go in on a delivery, when that mother's laying down and this baby's squishing everything here, you're going to see a lot more than you want to see. So don't be shocked by that. Notice the placenta is up high here, the umbilical cord. Remember I mentioned to you this is called the fundus. That's a word you need to be familiar with. You can see where the bladder is. So particularly when that baby is, you know, at 9 months and the baby's engaged. When you say engaged, we're not talking about, you know, passage of life where you're going to get married. Engages is where it actually seats itself in the birth canal. It's quite deep there. So this point, baby's not engaged. Once it gets down between the pelvic bones, then we say it's engaged. So, all right, that's good. Any questions about that? All right, there are 3 stages to the delivery of the baby. You need to be familiar with them because you may get a question on National Registry that will describe something that's going on, and they'll ask you what stage of delivery that is. So The first stage of labor is during the regular contractions, strong regular contractions that are leading to the birth. During the first stage, you're going to get that complete thinning of the cervix and the dilation, the effacement of the cervix and the dilation. And so once the cervix is fully dilated, the head's engaged, and birth is ready to occur, that's the end of the first stage. So the first stage is everybody getting ready for the birth. Oh, look what I have here. Look up. What should you do if the sac, the umbilical sac, isn't broken when the baby's head delivers? The amniotic sac. How do I say that? The amniotic sac. Y'all voting? What do you do if the sac isn't broken and the head is like hanging out? Come on, a couple more. Come on, come on. Hey, somebody hadn't voted. Come on. Huh. Let's see who's going to poke the baby's eye out with scissors. 15% of you. Who's going to slice the baby up with a scalpel? 38% of you. Holy cow, y'all killing me. The amniotic sac is a very thin, it's kind of like intestines. It's a very thin little thing. It's strong, but it's thin. So you're actually going to pinch it and kind of rub it between your fingers, and that'll break the sac. Please don't introduce sharp objects near the baby. I mean, none of you guys anyway, okay? You scare me. Okay. The second stage is going to be the actual delivery of the baby. It's going to begin right when everything is ready for the delivery, and then once the baby's born, that's going to be the end of the second stage. So the first stage is everybody getting all ready. Second stage is going to be the actual birth. So can you figure out what the third stage is going to be? Yeah. The third stage is going to be the delivery of the placenta. That's pretty gross, isn't it? Yes. It's really kind of cool. But you know, you can see how thin this membrane is here, right? So yeah, this is going to be the placenta. It's usually going to deliver, usually, 10 to 20 minutes after the delivery of the baby, and it's going to require contractions just like when the mother delivered the baby. So start contracting again, and you just hope it's not twins. And so you actually deliver the placenta. So you want to keep the placenta, you want to put it in a plastic bag, you want to transport it with you.
She should prepare herself before she
Prepare yourself.
Yes. No, that's the first thing I'm thinking about.
Yeah, well, I just hope she took a bath. All right, y'all ready? All right. Effacement occurs during y'all should have this. Come on, 2 more. Oh. Okay. We have some people that are not awake. Y'all want to raise your hands? That's 2 people slept through this. You were one of those? Just you remember what effacement is?
It's when the cervix starts to thin.
It's when the cervix thins out. So that's a requirement before the baby's delivered. What did you put? No idea. Okay. Who was the other person that missed that one?
They're not coming.
Yeah. Oh, you didn't vote twice on that. Somebody else in here is just not owning up to it. So at least he owns up to it, right? Okay, let's start looking at our patient assessment. Some terminology you need to be familiar with. Y'all gonna hate me after this. But gravida means number of pregnancies. So when you're discussing a woman's gravida, if the physician says, well, what is her gravida? He's asking how many times she's been pregnant. So if a mother has twin boys that are 3 years old, what's her gravida? That would be uno. Para is the number of deliveries. Yes,
If she has a miscarriage, that counts as a
Yes.
gravida, right?
it's a pregnancy, yeah.
And a more, we had to do that on the call, we had to use that,
Yeah,
that season, and we wanted to know that.
yeah. Okay, para is going to be the number of deliveries. How many deliveries she's had. So prima gravida would be the first time pregnancy. It's the first time she's been pregnant, prima.
Just looks like Spanish classes.
Looks like Latin class to me. Prima para is going to be a first delivery, right? Okay, gravida 3, para 2, that's the way it's going to be documented. Not with the 2 or the 3, depending on what it is. Each one's going to be different, but it's going to say gravida 2, para 2, gravida 3, para 2. So gravida 3, para 2, gravida means number of pregnancies. So we said 3 pregnancies, para 2 means 2 deliveries. So what happened there? Yeah, miscarriage or she had twins. Yeah. Okay, Braxton Hicks contractions, another phrase you need to be familiar with. Irregular, unsustained contractions. When a mom tells you that she's having labor pains, particularly mid-pregnancy, towards the end of pregnancy, she'll experience Braxton Hicks. And that's really like the body's just kind of getting ready to deliver. So the body's kind of practicing contracting, but they're very irregular. There's no timing to them. You know, one of the things we'll always do is start timing to see if they're regular. So there won't be any regularity. Now, she might start having them more frequently, but having them on Saturday night and then having them on Sunday morning, that's not any regularity there. So they're irregular and they're unsustained, so there's no pattern there. So it's just getting ready, but it doesn't have anything to do with the actual delivery. Term lightning. That's kind of an old term, but I've heard it more recently. Lightning means the baby's dropped. If you talk to those, those old LPNs from the olden days, used to deliver babies, or those midwives, they'll talk about lightning. Oftentimes the female can tell you that she knows the baby's dropped. She was aware of that movement down into the pelvis. Something else I was going to tell you, I can't remember. Okay, these are just some things as far as a pregnancy. We've talked about it. Things that have an inside and outside. Let's see. The heart rate's going to be faster. What about the respiratory rate? It's going to be faster. Where is the bulk of the weight going to be carried when the mom's pregnant? It's going to be on the front. So that causes what kind of problems? Balance problems and back pain. That's right. If you look through here, nausea and vomiting, she's going to have more heartburn, indigestion, because why? As she gets bigger, that pressure underneath her rib cage increases greatly, which that's going to make her breathe a little bit quicker. She's going to feel like she can't get a deep breath. She may get nauseated there or get indigestion because of the pressure on her stomach. She still wants to eat because she's feeding 2 people now, so her intake should be greater, but you'll find that she'll want to take smaller meals, because if she eats that, that whole hamburger from cheeseburger, she's not going to be able to get it all in there because there's not going to be enough space. So she may feel sick at her stomach or have heartburn or something. Shortness of breath as she gets bigger is not uncommon, just because of the pressure on her lungs. The diaphragm can't move down to expand her chest because there's somebody already there. Anyway, different things like that. I got a star here. Look, I even put a little outline on it. Why is it important to know if this is a first pregnancy? Everybody vote? Okay, good. Why is it important to know if this is a first pregnancy? It determines problems, determines speed of delivery, determines multiple births. Not really important. Ta-da! Determines speed of delivery. Usually the first pregnancy is going to take longer for everything to happen than subsequent pregnancies. The first pregnancy usually, like, what's your book say, 12 to 15 hours or something like that? Yeah, that would be on the short side.
First pregnancy though, or first delivery?
First delivery. Well, the first delivery of their first pregnancy. You know, the first time the baby's actually delivered. So yeah, their first delivery. We ask about pregnancy though, because how many times have you delivered would probably be the better question. So yeah, the more often she's delivered, you know, by that point, it's like anything. The first time you parallel park, it takes you a long time to get it.
I still can't do it.
Every time you do it, you get a little bit better. I am heck at parallel parking. If y'all got a problem, call me. I've done it a million times. I'm good at it. Same thing here. You know, when she's had more kids, it gets a lot easier. The body says, hey, I've got this. I just spread out and drop that baby. So, you know what I'm getting at here. It's muscle memory. The body's done it. The muscles are stretched. You know, the pelvic bones are already wider. So it happens much more quickly. So, yeah, I want to know if this is your first delivery or if it's your 10th. If you say it's your 10th, I'm calling for backup because we're probably delivering like now. So, if it's the first pregnancy, you probably bought yourself some time because she's probably much more nervous about the whole thing. You know, the first time she feels a cramp, she's going to call 911 and you're going, it's going to be about 4 more days. Call me back on my next shift. Okay, assessing the woman in labor. Assessment is focused on when she's going to deliver. You need to be able to recognize if it's an imminent delivery. Imminent means what? Right now. Yeah, are we delivering right now? Do we have time to put you in the ambulance and drive you to the hospital? Or are we going to have to stay here and deliver that baby? So that's what you're concerned about more than anything else. Now, some things you want to know. Of course, you're always going to get her name because it's a very personal thing for you. If you're delivering her baby, let's at least know her name, okay? And use her name and talk to her because you're going to be best friends by the time this thing's over. All right, so make sure you get her name. Find out her age. Why is her age important? Complications. Very young and then old on the old side of childbirth. Or it's like the difference in pediatrics and your geriatrics. So you're going to have problems at either end of the spectrum. So if the female is very young, I'm talking about 12, 14, 16 years of age. I know y'all going, what? Yeah.
That's ridiculous.
Yeah. I think the first baby I delivered was a 14-year-old. It was, I mean, not the baby wasn't 14. The mom was 14.
Dang, that took a long
Yeah.
time.
Yeah. Tell you what. So you need to know how old she is. If she's 40 years old, what types of problems are you looking at?
Extra chromosome.
Yeah, you're going to have birth defects. You know, that's where you see Down syndrome. That's where you see, do they have higher autism rates? A lot of things going on there. And they're usually not quite as healthy as they are, you know, when you're 21 giving birth. So either end of the spectrum, really young girls, their bodies are not prepared for delivery like that. So, excuse me. So the older and the younger ones you're going to have problems with. So you want to know their age. Expected due date. Is that important?
Yes.
Why?
The baby's really, really early.
Yeah, if that baby's early, and we say premature is going to be 37 weeks or earlier, would be considered premature. If it's 38, 39, 40, they're going to consider that to be full term. Excuse me. So you need to know the due date. If you go on scene and this woman is, if you look and she's crowning, you can see the baby there, and she says she's only 34 weeks, what are you doing? What? I'm calling somebody quick because you have a lot of problems when babies are premature. I always want to know if this is their first pregnancy. I should say first delivery here. I'm going to lose my voice here. I want to know if they've got good prenatal care. Women that don't have good prenatal care have a much higher risk of complications than somebody that's seen regularly. Some problems they can take care of, you know, they may be diabetic, they can manage that, you know, in their weekly or their monthly appointments. So you want to know if they've got good prenatal care. One of the questions I always want to ask somebody if they say they're seeing the doctor, I want to know if he's expecting any complications. Has he told you to expect any problems? Well, yeah, he told me I'm a high-risk pregnancy. Really? Why? I can't remember. I'm going to have to kill you. So yeah, you want to find out if they've got prenatal care and if the doctor's expecting any problems. And hopefully they're going to say no. All right, let's see what's next. When do the labor pains start? If she's having regular contractions, I want to know how long we've been having regular contractions. What else you want to find out? Are they, yeah, how strong are they? Is it like Braxton Hicks? What else do we want to know? Yeah, you mean are they regular or not regular?
Right, I mean, like.
Yeah, are they regular? The main thing I want to know is what? Do what? Well, that's important, but you can lose your mucus plug a day or two in advance of labor, so I would want to know that as part of the process. Do what? I want to know if the water's broken, but the main thing I'm looking for is how close the contractions are. If they're 60 seconds apart, I'm getting my stuff out in a really big hurry because you're going to deliver. So how close are they? If they're 10 minutes apart, even if they're regular, even if they're strong, if they're 10 minutes apart, I'm probably not delivering right away. So we want to know when they started and then how strong they are. Okay, question. Sorry, I went too fast. The urge to push indicates okay, so you know the vocabulary. All right, 3 more. Take a stab at it, guys. Good job. Nobody picked D? Good.
I know, that's what I was just thinking. I should have just done it.
Actually, usually this tells you that they're probably getting ready to deliver also. But the urge to push, once they say they have to push, that means that baby's coming. So you can get that out of your head trying to transport them because you're not doing it.
Is it true that that area splits?
Which splits?
That area between this one and this one? And goes
The the perineum? Yeah, well, it could split, yeah. You know, if the baby comes really fast before everything is really ready and softened up, it can happen. You know, if you like deliver, you know, King Kong or
I
something.
heard that like happened before. That's why I know.
Well, is that going to scare you now?
Yeah. That's coming like
Maybe you
worse
won't
than me.
reproduce
I'm like,
then.
oh,
Okay. All right, assessing the woman in labor. One of the early things you want to ask is if they feel like they need to push. You know, if they've got contractions and if she says or if you ask them, do you feel like you need to push, and they go yes, you just drop everything because you're delivering a baby. You're going to examine for crowning. You know, you get a call to one in labor. One of the early things you want to do, if she says that her contractions are very regular and they're fast, then you want to say, I'm going to need to check to see if the baby's crowning. So, you know, you're going to check, and you're going to be looking right at the vaginal opening for crowning. And that means the crown of the baby's head. So if you see the baby's head there, what's happening? You're delivering a baby.
It's kind of
Yeah.
like the other way. Was feet kind of poke out? Will you notice that, or is it?
You would notice a foot, yeah. It's like, or a hand, hey,
So
over
something's
here.
gonna be poking out. You're gonna be okay.
It may be, yeah. You hope it's neither a hand or a foot.
Yeah.
You hope it's just like a little head here.
What if it is though?
Times are tough. You just hope you've already called for backup. We'll talk about some of that too. You can place your hand on the mother's belly, on the abdomen, and you can feel those contractions. So you can time it very easily that way. And you want to time it from the start of the contraction to the end of the contraction. You know, how long did the contraction take? But you also want to count the interval between when one starts and the next one starts. That's what you're counting when you're looking for the interval. How close are they? It's the start of one to the start of the next. You're also going to take their vital signs. There can be complications. You want to look. You're looking for shock in case she's had some type of issue, which we'll talk about in a minute. But you want to go ahead and get your vital signs going here too. All right, you ready? Look at here. What does nuchal cord mean? If y'all don't get anything else from this class, you're going to get some vocabulary, huh? All right, one more. Make a stab at it. All right, let's see how he did. Not too bad. A nuchal cord means that the cord is wrapped around the baby's neck, basically. Now, who put A? I know what you're thinking of. Y'all know why he picked A? Who else picked A? A couple more of you picked A. Yeah, when you're talking about a nuchal neck, where it's very stiff from meningitis. We talked about meningitis, remember? So meningitis, we call that nuchal. When they can't move their neck, it's very stiff and it's very painful. In this case, we're talking about a nuchal cord. We're talking about it's wrapped around the neck. Maybe it's because it makes the neck stiff. I don't know. Okay, what do we got? So, we're talking about delivery, not about a nuchal cord, right? Yeah. Okay, just want to be sure. All right, so you ready to deliver this baby? So you're going to position the patient on their stomach, standing up,
On their heads.
on their head.
On their
Yeah.
bed.
You're going to want them, for the most part, we're going to have them laying on their back. Now, you know, in the delivery room, they do some different things. You know, like delivering them in warm water, you know, bath and different things like that. We're just going to lay them down, deliver a baby. Now, you can leave them on the bed, towards the end of the bed, and then you're at the edge of the bed down below. Makes it easy to deliver. More times than not, they're probably going to be on the floor is fine too. At least in the bed, you can have them propped up on pillows. You can have somebody help hold them up. But it's a little bit more difficult because you don't have that drop there. But you can do it. You want to create a sterile field. Now, I think next Wednesday, we're going to have our mannequin set up. We're going to be delivering some babies. That'll be fun. But you want to make the area as sterile as possible. But as possible is the operative word here. We are pre-hospital. You're going to be in somebody's home or the back of their car or out in the woods or in your ambulance. So you're going to do the best that you can with what you've got. So we have a little OB kit. We should have 2 of those on every ambulance because sometimes you have more than one baby at a time, which I don't wish that on you. But in there, you're going to have a sterile wrap that you can use. You'll have some sterile gloves that you can wear. But honestly, it's not going to be sterile. You're just going to make it as clean as possible. Be careful and watch your mom for vomiting. You know, you just hate it when you're down here trying to deliver a baby and they vomit all over you. So just keep that. Assess for crowning. That's one of the things you want to do early. If the baby's crowning, you're going to deliver. And as I said, as we started this chapter, that your goal here is to make the assessment about whether you're going to stay and deliver that baby or whether you're going to have time to transport. That's going to be one of your bigger decisions here. Now, when you think about the baby, remember when we did our rule of 9s when we're looking at burns? What's the biggest part of their bodies? It's their head. And the head is delivered first, and mainly, one of the main reasons is because it's the biggest thing. So one of its jobs is it's pressing down as it's engaging is to force all of that matter aside so it can be delivered. So the largest part is going to be delivered first, and everything else will just slide right on out. So one of the roles of the head is to put pressure on all that tissue to expand it so the baby can pass. So we want that head. So it's going to be under the most pressure. You know, all those muscles are pushing, you know, trying to force that baby out. So there's a lot of pressure there. Once that head clears, now what's going to happen? That old wet, slimy thing is going to slide out quicker than a greased watermelon. So as that head clears, you know, everything else is going to slide out very, very quickly. I don't know if you guys have done any reading or talked to anybody. There's been many, many babies that have ended up on the floor because it happens so fast and they're so slippery that whoever's in charge of that has not done a good juggling act. So that's the advantage of having the mother on the floor because they don't have far to drop when you drop that baby. So. But seriously, as the head is forcing, all the energy is behind it trying to force that big old blob out, and as soon as that passes, everything's going to come really quickly. You don't want that to happen. You don't want an explosive delivery, and that's what that is if that head is forced out very quickly and the whole body slams on out after that. So you want to put a little back pressure on the head so you don't get an explosive delivery. You want to guide that delivery so that it doesn't come out at 90, it just comes out at, 20 miles per hour. So you're going to kind of guide that head out. Now, if the sac is not broken, you're going to need to break that sac. And I would say probably less than 10% of the time is the sac not broken. And as I said, you're just going to pinch it between your fingers, and if you have to pull it away from the baby's face, that's fine. That's all I care about is the baby's face. So the head's coming down, you're just going to pinch it somewhere and just kind of slide that tissue back off of the face if it hasn't ruptured. Watch for the nuchal cord. Watch for the umbilical cord wrapped around the neck. It's not that common, but it does happen. Most of the time it's a single wrap that's very easy to release. What you do is you're going to slide your fingers up between the cord and the neck, and you'll wiggle it, and that'll loosen it. You know how you loosen your shoelaces? Just like that. You're loosening that, slide it over the head. Now occasionally it may be wrapped several times. If it was particularly long, the baby was particularly mobile, it may have wrapped it several times. In that case, you're probably not going to be able to get it over that way. You may give it a shot, wiggle your fingers if you can loosen it so you can get over the head. That's the best thing. But if you can't, then you're going to have to clamp it and cut it, because baby can't ride hanging halfway out like that, right? So you're going to have to cut it and clamp it. So we'll talk about doing that here in a minute. So nuchal cord, if it's wrapped around the neck, you're going to try to scissor it. I don't mean with scissors. Your fingers, you're going to try to loosen it, and wrong word to use for you guys, and lift it over the baby's head. Okay, next thing, and all this is just as the head's delivered. We're not talking about after the whole body's delivered. As soon as the head's delivered, we're going to go ahead and suction. We're going to suction the mouth and the nose. And that is an important order that you must remember. You think of it, I remember it in alphabetical order. The mouth and then the nose. Okay, now once you've suctioned the mouth and then the nose, and when you suction it, we have a little bulb syringe. You've seen it, the little blue thing. You're going to squeeze it down, put it in the baby's mouth, and then release it. And you may have gotten a bunch of gunk there, so then you're just going to turn away and somewhere you're going to squirt it out. You're going to come back, you're going to do the nose the same way. You'll depress it, put it in the nose, let go, squirt it, depress it, put it in the nose, and let it go. Alright, so once you've done that, we're ready to deliver the rest of the baby. So you're going to support the body as it comes out. Remember, we put that back pressure on the head so we don't have an explosive delivery, so we're going to guide the baby out. Now, we call that the cephalic position, meaning it comes head first. Usually the head is kind of down, so the baby comes out, it's down, and then it's going to rotate a little bit. Usually it rotates to the left, is that right? This way, that way. It's going to rotate clockwise, usually. Not always, but they're going to rotate that way. And then you'll kind of dip the shoulders. The shoulders are kind of wide. The head's round, it's spread everything. So you're going to dip a shoulder and dip a shoulder. Usually down and then up, baby will slide right out. You'll get it. It won't be a problem for you. You don't believe me? You will. Alright, so once the baby's delivered, you may take a gauze pad and clean the baby's mouth out. You may kind of squeeze the nose down. You may need to suction again. All this is for a normal baby, with no issues. Baby should start breathing. One of the functions of, we go ahead and suction the mouth and the nose before the chest is delivered, because one of the things that's occurring with the chest, once the chest is squeezed, as it's squeezed through there, that's going to help move mucus. It's one of the functions that it does is it moves that fluid out of the lungs, so that once the baby's delivered, the lungs are clear of fluid so they can breathe. If the nose and the mouth are full of crud, he's not going to be able to breathe, right? What did I tell you earlier about babies and the O word? What kind of breathers are they? They're obligate nose breathers. So that's why we suction the mouth first. We're going to clean the mouth out so that when we clean the nose out, they're going to take their first breath probably through their nose because they're screaming through their mouth, right? So they're going to be, not really. They can't scream and breathe at the same time. So they're going to breathe through their nose. You want that clear. So then as they complete that process, moving the fluid hopefully out of their lungs, that pressure stimulates them to breathe. So most of the time once they deliver then, they're going to start breathing. So you'll clean out their mouth and nose. Yeah.
So you're saying their first breath is through their nose?
Usually, they're obligate nose breathers. They're going to more naturally want to breathe through their nose.
Okay, but we clean the mouth out first.
We clean the mouth so that when we do the, all right, if you had a bunch of gunk in their mouth and then they start to breathe through their nose, it's going to suck some through there. So you want to clear the mouth, but once you clear the nose, that really is what stimulates the breathing there. So, or
You also
part of the
said
process.
Suction the mouth and nose when it's coming out and they're still at the chest.
Yep, When the head's hanging out, because you've controlled that delivery, so when the head's still there, you're going to suction that really fast and then deliver the rest of the body. And then if you need to suction again, or, you'll be able to see if they've got a bunch of mucus and crud around their mouth. You can use a, 4x4 with your finger and kind of clean that out. All right, let's see. Now, next, after you've done your suctioning and cleaning the nose and mouth, we want to dry warm position. Yeah. Several things you want to do, and these are very important. You want to dry them off. They're wet, right? What's the problem with them being wet? They lose a lot of body heat. Remember, I told you how much faster you lose body heat? Yeah, they're going to lose it 20 times faster when they're wet than when they're dry. So you want to dry them off because, remember, babies are, because of their high surface area compared to mass, they lose body heat very quickly. If they're wet, they're going to really lose body heat quickly. Now, newborns, very young babies, do not thermoregulate well. That's why you'll see moms, with their little strollers and they got babies all bundled up, hats and all this crap on, and you're going, oh my gosh, it's 1,000 degrees outside and you've got them all bundled up. It's because they can't thermoregulate, so we have to do that for them. So we want to make sure we dry them off and we cuddle them up very quickly to keep them warm because they're going to lose a lot of body heat very quickly. Imagine for the last 9 months, they haven't had to do anything to keep themselves warm. Somebody's been warming them all the time. And all of a sudden you deliver them. What's the delivery room temperature? Yeah, 32, 40. Yeah, it's really, really cold. So you got to make sure that you dry them off, you get them wrapped up very quickly. Now, position. What do you think we're talking about here? Bonding? Bonding's nice. Remember the other night when we were talking about our special patients and we were talking about the urine bag, if a patient's catheterized. And remember I said if you raise it up here, where's all that urine going? Right back, certainly. Same thing here. That baby's attached by an umbilical cord, right? Hey, somebody coming. If you hold that baby well above the mom, they're going to auto-transfuse. So a lot of that blood is going to flow backwards back into the mom. If you hold them way down, now what have we got? The opposite direction. So you really want to keep them pretty much level with the mom's vagina. You want to keep them level with the mom. You don't want to raise them up or lower them down until you cut the cord. Okay, now one other thing I probably should have mentioned with this dry, warm position, you also want to stimulate the baby. I mean, if they're already screaming and carrying on, good to go. But if they're quiet or they're not moving, you want to stimulate them. And we're going to stimulate them usually by rubbing the bottom of their foot or rubbing their back. Remember in the olden days, you say you held them up by the feet and you gave them the spanking thing?
I have
No,
a
we don't do
picture of
that.
me like that.
They did
I
that
was
to you?
down.
Well, that probably is the explanation,
I
yeah.
know.
But yeah, we don't really do that. Just stimulate them on their back or their feet or something, okay? But usually, they're going to start screaming up pretty quick. Now you've got two patients, right? So somebody's going to need to monitor the baby. Somebody's going to need to monitor the mom. Somebody's going to provide care for the mom. Somebody's going to provide care for the baby. So this is why we call for backup. If you have an imminent delivery, if you get there and you see crowning, I'm on the horn pretty darn quick because I need some help there. Because you can't drive and have somebody take care of both of your patients. It's just not safe. Okay, now you usually are going to clamp the cord within the first minute or so. Some new documentation I read the other day that they're saying that it's better if you leave the cord on for 1 to 3 minutes. I don't care what you do. Just recognize that the baby's going to be losing heat through that cord. So usually within about a minute or so, you're ready to cut the cord. A lot of things are happening with the baby before you cut that cord. The mom's starting to clot off, starting to decrease the blood flow to the cord. You know, the placenta's starting its little separation duties. So a lot of things are going on here. So you want to, when you clamp this, and the book says one thing, every textbook you read says something different. And I've talked to a couple of obstetricians about this. They all do something different. But when you set your clamps to clamp the cord, you want to leave some space between the baby, you know, the baby's skin, and then go up maybe about this far, maybe 4 inches or so. Put a clamp, then put another one 2 or 3 inches away, and then you're going to cut between it. So you're going to clamp far, and then clamp close, and then cut in between. Now in your kit, you're going to have these nice little clamps, and you're going to have I can't talk tonight, I'm so tired. Well, come on, y'all, help me out. Scalpel, yeah. Why do I record this? Just to torture myself? Scalpel. Use a scalpel to cut that. Then you're good to go. And what are you going to do with all that, the rest of that umbilical cord? Yeah, we're going to keep it because the placenta's got to deliver. We've clamped it off, so we shouldn't have any bleeding issues. But once you've got that thing clamped, make sure you've totally wrapped up that baby.
What if the placenta doesn't come out? You ever had that problem?
I haven't had that problem,
They had-
but
they
it
told me
happens.
They had a delivery at work like a week or 2 ago, and they said that I forgot what they said they had to do, but the placenta wasn't coming out.
If you're on scene, on a site, it's going to be different than if they're in a hospital environment. We'll usually wait 10 or 15 minutes or so for it to deliver. If it doesn't deliver, we're going ahead and transporting. When it does deliver, you want to make sure you capture it in a plastic bag because it needs to be taken to the hospital along with the mom and the baby. So you want to capture that. But if it doesn't deliver, it doesn't deliver, and you just go ahead and transport, and they'll sort it out when you get there. Now, mom loses a fair amount of blood during this whole process. Everything in her body's not going to clot off, so there's going to be some bleeding. Normal blood loss is going to be about 500 cc's. So that's normal blood loss. Could she bleed more than that? Yeah, she could. How do we control bleeding? Yeah, direct pressure. So this is bleeding. You're just going to take pads and you're going to put it over the vaginal opening. Apply a little bit of pressure. She'll probably just pull her legs together, hold that in place. And that's usually okay. If it's a lot of bleeding, we're going to use a tourniquet, right? Okay, thank you. Just checking. Just checking. Yeah, we're not going to use a tourniquet. Where would you put it? So you're just going to put more pads on there, just like you would with any severe bleed. Just more pads. That's also a way they can judge how much blood loss. So if you've got a mom that you're having to put a lot of pads on there because she's losing a lot of blood, now what's your problem? Yep, the big S word, shock. So yeah, this is why you need somebody taking care of the baby and somebody taking care of the mom. So we know how to treat shock, right? From blood loss, how? Oxygen and warming, yeah. You might consider positioning, you might put her head down, something like that. But you got to keep her warm. She's going to get very cold. One of the functions of the baby, you know, she's got that baby in there. That baby serves to keep her warm too. Between them, they're kind of warming each other. Once that baby leaves and she has a lot of blood loss, she's losing a lot of heat. So she's going to be very cold too. So between the mom and the baby, you're going to have the heat on in there. And then record the time of delivery, and then ask the mom if she's going to name it after you. All right. Okay, this is a picture of crowning, in case y'all missed that. The baby's head right here at the opening of the cervix. Yeah, little baby fuzzy head there. If you come in and you see that, get your stuff out, right? All right, good. Okay, question. Which of these will most likely need resuscitation? Come on, a few more of you. Just take a stab at it. Last one. Okay. Well, what do we know about a baby that's 38 weeks? Full term. Remember we said 37 and earlier is going to be premature, so 38 is going to be full term. What's multipara? Okay. So she's had multiple deliveries. That just means she's going to deliver fast, right? Okay. Full term delivery. Good, nobody picked that. Twins, only 15% of you picked that? Oh, that's interesting. Yeah. Twins are almost always premature. You just hardly ever hear about multiple births that go full term. So of these choices, you're more likely to have to do a resuscitation on twins simply because they're premature. They're premature, they're also probably going to be smaller. There are exceptions to the rule, but most likely that's going to be your issue. Findings that indicate possible need for resuscitation. So this is going to be times where you may have a reasonable expectation that you may be doing a resuscitation. If they've had no prenatal care, that greatly increases the risk of a complicated birth. So if you get there and she says, no, I haven't been to the doctor, your response in your mind is going to be, oh, feces, right? If the baby is premature, which is going to be 37 weeks or above, you know, if she's in full contractions 1 minute apart, you're delivering a baby and she says she's only 8 months, you're going, oh, feces. If she is going into labor as a result of a traumatic incident, that's never good. If the mom has sustained trauma bad enough to cause her to go into labor, you're looking at traumatic injuries too. When you look at some of the things that can happen trauma-wise to a mother during pregnancy, it can be quite bad. If she says, you know, I'm having triplets and the first one's crowning, you once again are going, oh, heck, why didn't I call off today? Or, gee, wish I'd known so I could have called for 3 backup units. So other issues, a history of problems in pregnancy. You know, if she's had a breech presentation, you know, the more breech pregnancies you've had or breech deliveries, it greatly increases your chance of having more. My daughter's pregnant right now. She's had 2 breaches already. So this is her 3rd, and the baby's breech. So we're having a 3rd breech, I'm afraid. So yeah, if they tell you it's breech, you're going, oh, whatever.
Can they not move the baby?
It's difficult. If you start being very traumatic like this, you run the risk of, you know, disrupting the placenta and
So
stuff.
like right now, its head's up here and its feet's around here.
Yeah, kind of like that. Yeah. If they've had placenta previa, we're going to be talking about that in just a minute, problems with pregnancy. If they've had hypertension, if they've had seizure, a lot of different things, you know you're going to have some serious, it greatly increases the chances of a problem. If they are drug users, somebody told me the other day, a good source told me that babies born today, that something like 75% of them are testing positive for drugs. That is a huge number. But drugs during delivery can be a problem for you. You know, if a patient is taking, you know, opiates, you may have a baby with severe respiratory depression, you know, or other things. Alcohol, fetal alcohol syndrome can be very problematic. Meconium, this is a word you need to know. Meconium is actually fecal matter inside the amniotic sac. And if the baby is actually circulating this through their body, it's not a good thing. Meconium usually occurs during delivery or during labor, and it's a sign of some type of fetal distress. It's really the baby's first bowel movement. So we like for that to occur after delivery, But if there's some type of stressful event occurring, it may occur just prior to delivery. We do not want that in the baby's lungs. So we call that meconium staining, and it's kind of going to be brownish or greenish, and you'll see that the amniotic fluid is discolored with this material. So this is where it's really important that we suction well, because we do not want the baby to aspirate that. It really sets them back quite a bit during those first few days of life. Okay, how can you get necessary information from a patient who may be having uncontrolled pain from contractions? Yeah, hopefully there's somebody around there that can give you some answers, but it can be very challenging. What time is it? Okay. Let's go through normal childbirth and then we'll take a break again, okay? Got a question for you. Y'all ready? You awake? Which is a normal delivery presentation? I already told you that. You missed this. I'll know you're sleeping. Do what? Who missed that one? Head first. Alright, head first. It's normal. Okay, face down. Well, okay, that was my fault. Normal, they're usually face down and they're head first.
So on a test, which one would it be?
I hope I wouldn't give you that one. I would hope I wouldn't make that mistake. I made it here. Won't make it again. Okay, I mentioned cephalic delivery a few minutes ago. This is that poor little old baby's head coming. You can see because his head's kind of, go back. It's kind of up, then he's already kind of rotated around, or else he just came face up. But they're not usually going to come face up. It may be sideways, but it's usually going to be down, and then they'll rotate right away to get that shoulder out. Cephalic delivery.
How do you get it, like your shoulders are like stuck in there?
One goes and then the other. You kind of dip one in and let them come. All right, let's talk about imminent delivery. If you have an imminent delivery, you're going to deliver this baby. It's important that you control the scene. Particularly if it's the mom, if it's her first child, she's going to be freaking out probably. You know, she hasn't been through this before. Once you've done it, you know, it's, I got this. Same thing for you. Once you've delivered a baby, it's, I got this. It's no big deal. So it's important that you control the scene. This may happen while she's got all the family over for Thanksgiving dinner. You know, who knows? Or she's called all her friends, I'm having labor pains. You know, everybody runs over and all of a sudden her water breaks. And so you want to make sure you control the scene, that you don't get freaked out. Clear all the people out of the room. Give her some privacy. If she says, I want my husband in here, fine. If she says, I want my mother-in-law, you say, are you sure? But, you know, just because so-and-so wants in there, that doesn't mean they get to, you know, they say, I'm the baby daddy. I need to be in here. And she's going, no. Then who wins that one? Yeah, she's going to win that one. So if you have any issues, you just call law enforcement. But make sure you're in control of that scene. Chaos is never good. Proper PPE. What are we talking about here? Yeah. Everything known to man.
Yeah, hazmat suit.
Yeah, hazmat suit. Yeah, Tyvek suit. These can be quite messy. So yeah, you want to have your gown on. You want to get all suited up. I'm probably going to put 2 or 3 layers of gloves on here. I'm going to have a shield for sure, and probably a mask. So you want to pretty much put on a spacesuit here. Put the mom on the bed, the floor, the ambulance stretcher. You want to avoid the ambulance stretcher for delivery when at all possible. Any ideas why?
Because it's like nothing.
Yeah, you got to clean that thing up. You don't want to deliver in the back of the ambulance. Woo, nasty. So you want to do it at her house. They'll call in, you know, who's that group that comes in and cleans your house after a fire? ServPro. You're going to be calling ServPro after that. Or get them to the hospital. Okay, you want to remove the clothing, you know, from the waist down, so you can get an unobstructed view, so you can enjoy the experience. But actually, try to deliver a baby through a pair of, you know, stretch pants. It's not going to happen. So you're going to have to get the clothes off. You're going to need some help here. You're going to get your OB kit out. You're going to spread out, you know, your sheet or your towel, whatever you've got. Here's a little picture of it. It's the stupidest picture. Put your little pad under, slide it down, cover them up. You want to maintain their dignity the best you can. If it's her first baby, you know, she's probably going to be a little timid, you know, cover me up. After that, it's like, get the baby out. Do it. Do it. Okay, these are the things that are in your OB kit. You're going to have either a scalpel, see I got it that time, or some scissors. These are going to be your little clamps, your cord clamps. These are your sterile gloves. These are different than the ones that come out of the box. They're going to be all wrapped up. They're going to be sized and stuff. So you'll have your sterile gloves. I'm not going to be needing any tape here. What are we going to use this plastic for? The placenta, that's right. What are these little things for here? Yeah, it's probably going to be your pads, your vaginal pads, you know, different things. This will go under mom because it's got a plastic backing. This is just like a little sheet or something. And this is our bulb syringe, right? We're going to get that nose and mouth. Oh, had to start, didn't even realize it. Which of these can be used to clamp the cord during off-duty deliveries? You know, like when you're at the Target or something. One more. Okay. All right, that's interesting. Paper clip, really? Who put that? I think 2 of you did, I think. Anyway, yeah, probably not so much. Yeah, shoelace. This is not going to be like a regular tourniquet where it's got to be 2 inches wide. Shoelace is fine. Yeah. Paper clip, tourniquet, really? Clothespin. Clothespin's likely to come off, guys. Okay, off-duty supplies. You're going to need some clean sheets and towels. Shoelaces over twine, I think. Something that you can tie a good knot with. Plastic bag or something to collect the placenta. You prefer a towel, you prefer a plastic bag so you can kind of encapsulate all the material. Towel's going to soak through. Some unused rubber gloves. Notice eye protection. You're going to need something over your face. And not a bag. You wish for a clear bag. Okay, are there any legal, moral, ethical concerns for an off-duty delivery? Y'all not going to be like doing any cesareans, are you? Okay. As I said before, delivering a baby is a BLS skill. Anybody can do that. Gosh, the father of the baby does this sometimes. So it's not that big a deal. So you just got to be careful and do only what's in your scope of practice at all times, which is BLS. You can do that. Okay, delivering the baby. Notice the position of the baby, head down, head first, right? Once the baby's head clears, you want to suction. And notice now we've got a shoulder that's up because the babies they automatically rotate. As the head comes out, they twist a little bit. So you got one shoulder high and one shoulder low. So whichever one presents first, this one, what you end up doing here, if you can see the top shoulder is closer to delivering. So they're taking the baby and dropping the baby down just a little bit to release that shoulder. Once that shoulder's released, they're going to bring the head back up and release the other shoulder. Like that. Now notice we have a firm grasp on this baby because he is slick E. Is that a word? He is slick times 10. So you want to make sure you have a good grip on him. If you have a towel, grab him with a towel with lots of little nubbies on it. Not a little slick towel. With a real towel so you can grab him a little bit better. And out he comes. There we go. Hold on to him. It's going to get away from you. Wasn't that easy? So once you pull this baby out, what's the first thing you're going to do?
Spanking.
No, we're not
You gotta
spanking
clean
him. Yep. You got to dry him off, right? Keep him warm. What are the other things that are on that slide? Position him properly. If he needs stimulation, you may stimulate him a little bit. If you need to suction again, you may suction. So position means you're not going to pull him and lay him up over here on the counter and start working on him, because what's going to happen? Yeah, but you're going to pull this cord. You're going to rip that placenta away from mom, and what's going to happen? Did Rip kind of tell you what's going to happen there? she's probably going to bleed to death before you get her anywhere. So you got to be very careful you don't pull on that cord. Tugging on that cord in any way, it's like picking scabs, only 10 times worse. You know, if you pick it and it's not set, you're going to bleed. Okay, the neonate. Remember who's the neonate?
12:30.
Yeah, 0 basically to 1 month. Here we're really going to be talking about the newly born. So, y'all ready for a question? What is the term for a 2-week-old baby? Man, I've got to quit doing that. If y'all don't get 100% on this, 2 weeks old, what did I tell you newly born is? 24 hours. Okay, your assessment of your baby. Remember we said you got to keep them warm. Heat is your highest part, well, after respiratory. But for a normal delivery, heat retention is extremely important. They will get cold very rapidly. Once they get cold, they're going to become bradycardic. Once they become bradycardic, they die. Dry them off. Get rid of wet blankets or wet towels. Bring in some dry ones. Keep them wrapped in a dry blanket. Don't wrap them in that old wet blanket. They're going to keep losing body heat. We carry these little aluminum sheets on the ambulance. If you haven't seen one, watch for those. I mean, they're dadgum aluminum. It's a space blanket. But what it does is it doesn't allow, you know, any moisture to get through that. So you can swaddle them up in that if you don't have a blanket. Make sure you cover their head. Dry their head off and cover it. They lose a large percentage of their body heat through their head, just like all of us. Okay, cutting the cord. You want to, if you can, you want to wait till the cord stops pulsating to cut it. But usually you're talking about a minute or two. It'll stop and you can clamp it and cut it. As I told you, you know, this is what your book says about the dimensions here. That really is not that important. And you shouldn't get that asked exactly like that on registry. You'll put the clamp furthest from the baby and then the second clamp closer. Make sure you leave 2 or 3 inches in between to get your cut. They use this cord for different things. They cannulate it at the hospital if they need to, which means they can put like an IV in there. If they have to give the baby fluids or something, it's a great access. Why is it important to stimulate the baby? Yeah, once they start breathing, that air, you know, as they bring it into their lungs, is going to help facilitate the movement of that fluid out of the lungs. Because remember, when they were in utero, fluid has been moving through their lungs. So once the baby delivers, things take place there, so now they can be air breathers. And so they've got to help move that extra fluid out. So they have to breathe. Sometimes you have to stimulate them. There's a couple of different things that go on here that may prevent the baby from breathing. So you want to stimulate them, make them start screaming up so they'll breathe on their own. Okay, there's something called the APGAR score. You need to be familiar with this because you will see it again. Once a baby's born, usually at 1 minute and 5 minutes, we're going to assess their APGAR score. 1 minute and 5 minutes. Does it have to be exact? No. If you're busy doing CPR on a baby, I don't want you to stop doing it at 1 minute so you can do this assessment. This stuff is pretty easy. Appearance, pulse, grimace, activity, and respirations. So you've got 3 choices here. If they don't have any of these, they get 0 points. If they have it but it's not great, they get 1 point. If they're really vigorous, they're doing it a lot, they get 2 points. I think I have a chart coming up. Yeah, I will in a minute. I have a question for you. We're going to go through this, so y'all ready? What does the G stand for in the APGAR score? See if you remember. Hey, you held a thought for 30 seconds? Good job. Okay, yeah, you know, let me go back to the APGAR score then. Because I must not go in. This is in your textbook, so make sure you read through there. Appearance is their color. Are they blue? Are they pink? Are they pale? If you have a baby that's blue, is that good or bad? It's always bad. So if they're blue, if they have central cyanosis, we know what cyanosis is, so central is going to be the torso. So if they have central cyanosis, they're going to get a 0 there. If they have peripheral cyanosis, but they're pink here, then they'll get a 1. If they're pink all over, they'll get a 2. Does that make sense? So it's all color-based. If they're big time blue, they get what? 0. If they're just a little blue, 1. And if they're pink, then they get 2. It's not unusual for a baby to be a little blue on the edges. They may remain blue, peripheral blue, up and for a couple of weeks after delivery. It's not unusual. So it's okay if you ding them a point if they're a little blue around the edges. Okay, the pulse. If they don't have a pulse, 0. If they have a pulse but it's under 100, they get 1. If it's over 100, they get 2. What would be a normal pulse at delivery for a baby, newborn? About 140. 140 to 160 is normal. So if it's above 100, then we're okay. If it's below 100, not so good. Okay, grimace. This is going to be, what they're doing. Are they got it all squunched up because they're screaming? That would be a grimace. If they're laying there quietly, if they're not showing any facial movement at all, they're going to get what? 0. If they're kind of going like that, how am I going to get that on screen? Just a little mild movement of the face, and they may get 1. If they're giving the whole scream thing and their face is all bent out of shape, then they'll get a 2. Activity. Now we're talking about the arm and leg movement. You've seen pictures of this, I'm sure. Babies are born and they've got this whole exercise thing going. The arms are going, the feet are going. That's a good sign. So if there's no limb movement when they're born, they get what? 0. If they're just moving a little bit, they get 1. And if they're, boxing for a living, then they're going to get 2. Okay, that's activity. Last one is respirations. Normal respiratory rate for a newborn would be what? Probably 30 to 40. They breathe pretty fast. They get after it. So if they are not breathing at all, 0. If they're making respiratory effort, but it's like low, 1. And if they're breathing normally, 30 times a minute, then I'm going to give them a 2. So their high score is going to be what? 10, yeah. It's not unusual to have a 9. If they have a 9, it's probably because of what? Peripheral cyanosis. That's right. Okay. All right, y'all ready for a question? We did? Oh, that's right. Good for you. All right, this is the inverted pyramid. And you do need to know this because you'll see it again, but it also is going to help you when you're deciding how you're going to manage a newborn. As I said, most deliveries are normal. 95, 96% of them, no problems. But this is going to be your inverted pyramid, your resuscitation pyramid. This one at the top is what we do normally, right? Drying, warming, positioning, suction if they need it, and then tackle circulation, stimulation. So that's 5 things. You're going to do this for normal deliveries. Every normal baby, you're going to do this. Now, if they have any issues, you can do the APGAR score. If they are only breathing 10 times a minute, something like that, 20 times a minute, you may give them some oxygen. If they've got central cyanosis, you may do some blow-by oxygen. So you'll have to determine based on their pulse and their respiratory status if you need to do anything else. But the next step is going to be oxygen. Very frequently, that's all you need. A little blow-by oxygen, fix them. Now, if you give them blow-by oxygen and they really don't increase their heart rate or they don't increase their respiratory rate, then we're going to start bag valve mask. So we will bag them, and if the other things hadn't fixed them, this almost always fixes them. So with kids, the most common problem is going to be a respiratory problem. So there are some circumstances where that delivery process, it's almost like it paralyzes the medulla oblongata. It paralyzes their respiratory center. So some bag valve mask will very frequently cause them to start breathing. If that doesn't do the trick, If their heart rate doesn't pick up, then you're going to do chest compressions. 99% of the time, if they're going to survive, this is going to do it for them. Once we get to the ALS part where they have to intubate and give medications, there's extremely low chance that that baby's going to make it, particularly in the field. It's just probably not going to happen. In the hospital, they run a much greater chance because they've got everything they need to do any intervention. So, no, the first one's particularly drying, warming, positioning, suction, and stimulation. And then if all that's not doing, the baby's still under distress, we're going to consider blow by oxygen. If that doesn't fix them, then we're going to bag them. If that doesn't fix them, we're going to start CPR. So we're going to talk about this a little bit more closely as we move along. Okay, I know I made you mad because I touched your little button. Okay, now in the event that you have to do a resuscitation and do CPR on a baby, you want to do this, they call it chest encircling. The best way to do this is to bring your hands behind the baby's back and do chest compressions with your thumbs. That's going to be your best way, chest encircling. So if you see that on registry, that's the terminology that you're looking for. So you want one person doing the chest encircling and then somebody else bagging the baby. So that's a two-person activity here. Okay, there's some things you need to know about CPR on a newborn that's important. There are some values here that you have to know. So you can write these down, commit them to memory. When do you start CPR on a newborn? If the heart rate is below 100 beats per minute, you're going to ventilate. Okay, heart rate. Heart rate is the key to resuscitation in a child. Remember I told you if they're not getting enough oxygen, what happens to the heart rate? They become bradycardic. What happens to you first if you're not getting enough oxygen? You know, heart rate wise. You initially become tachycardic. And then if it is prolonged, you'll become bradycardic. With the newborn and an infant, they're going to shoot right to bradycardia. Once they become bradycardic, it's very difficult to salvage that child. So if the heart rate is below 100, remember our Apgar scale, you know? If it's below 100, then you need to be ready to ventilate that patient. So you're going to start ventilating. Because here we're looking at heart rate. We're not looking at respiratory rate, we're looking at heart rate. If the heart rate's below 100, you're going to ventilate 40 to 60 times a minute. Heart rate again. If the heart rate is between 60 and 80 and you're ventilating, they're not getting any better, you're going to start CPR. So I know this is confusing for you. So at 100 beats a minute or below, if it's below 100, you're ventilating them. That means a bag valve mask. If you're ventilating them and the rate continues to drop, or say the first time you check their heart rate, it's between 60 and 80, you know, you're going to ventilate them for 30 seconds. If they don't get better, if the heart rate doesn't get over 100, then you're going to start chest compressions. Does that make sense? Anytime the heart rate is below 60, you're going to be doing chest compressions at the rate of 120 per minute. Remember, on regular CPR, what's the rate we do for everybody? The rate of 100 per minute. A newborn, we're looking at the rate of 120 per minute. So, if they have a heart rate of 90, what are you going to do? You're going to bag them. So you're bagging your patient. They have a heart rate of 70. What are you going to do? Depends on if it's going up or going down. If they're improving, say they had a heart rate of 60, and you, remember I told you, a heart rate between 60 to 80, if that's the first time you check it, you're going to bag them for 30 seconds first. You're going to see if that's going to fix them. If you start bagging them and they don't improve, they're not improving, you're going to start chest compressions. I would not be surprised if you got a question about this on National Registry. You just kind of commit these values in what you do. Commit that to memory. Y'all ready? What is the first step in the neonatal resuscitation? The 5 steps. What are they? Dry, warm, suction. Oxygen's not up there. Position and stimulation. Yeah. You want to say them again? Dry, warm, position, suction, stimulate. Good work. What is central cyanosis? Right. It's going to be the torso. It's going to be cyanotic. When is artificial ventilation required? If the heart rate is below 100. When is CPR required? Heart rate below. Yeah. It's required when it's below 60. When is it in between? Between 60 to 80. If it's not improving, we're going to do CPR. What's the rate of artificial ventilations? 40 to 60. What is the compression rate? 120. All right. Y'all want to take a short break? Yeah, it's freezing in here. Yeah. Y'all take a few minutes. You're hungry? I'm freezing.
I wouldn't have time to go down there.
We don't-
Read it. I don't know, I can't read it.
It doesn't say.
Oh.
Resume. Okay, y'all ready? Got your clickers? All right. The mother is at increased risk for. Talk about this. Make it way too easy for you. All right, couple more. Come on, come on, come on. Back, 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 back. Okay, we got some people that were awake. Pulmonary embolism because your increased clotting factor. Yeah, I did tell you guys that early on. Okay, now we've delivered the baby. Somebody's taking care of the baby. So now we got to worry about the mom. So we got to be concerned that she may have some serious bleeding going on. We have to worry about a pulmonary embolism. Of course, there is a chance she could get an infection, you know, depending on, say, her water broke some period of time before she actually went into labor, and so she had the opportunity to get an infection before you got there. It's possible. Make sure you comfort her. You know, she's after the baby's delivered. I can't remember if we're getting ready to go into that. You want to put the baby to the breast if at all possible, because that sucking motion, if the baby will try to nurse, that helps to shrink the uterus down, and that also is going to help that clotting factor. So it's going to help reduce the bleeding. So putting the baby to nurse soon after birth is extremely important to controlling bleeding from the mom. Delivering the placenta, that's the afterbirth. That's going to be the placenta and the rest of the umbilical cord and anything else that's tied in there. All the lining, the tissue that's lining the uterus, all of that should be passed. You want, as I said, be very careful you don't pull on the umbilical cord. You don't want to pull this thing out prematurely. As the placenta starts to deliver, the mom's going to start having labor pains all over again. That's going to cause the placenta to detach from the uterus and then move it down the vaginal canal, and it will also be born too. Don't resuscitate it. Usually 10 to 20 minutes. It may take longer. We'll stay on scene for 10 or 15 minutes maybe to deliver, but don't stay any beyond that. Just go ahead and get rolling. Is there a question?
Yes, so the labor pains for the placenta delivery, is that going to be as strong? as
No,
the
no.
contraction, or just gonna-
Yeah, I mean, they'll be cramping. It just feels like cramping as they deliver that. Yeah, don't wait for the placenta. You know, give it a few minutes. If it doesn't come, I'm going to go ahead and roll. But expect it to deliver en route, so make sure you're prepared for that, okay? You know what I'm saying here? Okay, to help control vaginal bleeding, of course we're going to treat them for shock. Keep them warm. You may elevate the feet a little bit. That's good. Notice, I know you can't tell what that blob is here, but that's the baby at the breast. And this this is you in this green gown with all that fuzz on top of your head. It looks like a monkey, the Planet of the Apes or something here. But you're going to massage the fundus. You'll do a fundal massage. That massage, the fundus is right at the top of the uterus. The uterus now has shrunk down pretty good, so that you're really doing a massage, a uterine massage here. So it's kind of a twisting motion like this, a little bit of pressure, that you're kind of doing that to massage the uterus. Now she's showing the two-hand motion. You can do that kind of side to side. You're kind of squeezing on it, and that massage will help control the bleeding, as well as in addition to the baby nursing. Yeah, okay. Comfort for the mom. Make sure you take the vital signs frequently. There could be internal bleeding there, so you will monitor that by monitoring the blood pressure, right? She's going to remember how you treated her. You know, she's not going to remember if you clamped the cord 4 inches from the baby or 5 inches from the baby. She'll remember if you were nice, if you cared for her health and her warmth, and that you took good care of her. She's worked really hard to produce this baby, so she wants it, you know, fix her hair before she goes rolling. She's going to be getting her picture taken all over the place, right? So, you know, you can wipe her face up. Replace the sheets, put some clean sheets on there. Nobody wants to be rolling around in some nasty old sheets. You're not even going to want to see it yourself, so get rid of it. What are your responsibilities in caring for the mother? I just told you. What is considered to be usual blood loss? About 500 cc's. Yeah. Birth complications. You ready? Ooh. Breech presentation. It's considered breech if anything other than the head presents first. So if it's an arm, it's a leg, 2 legs, whatever, it's going to be a breech presentation. If the butt, you know, the baby could come all folded up like this, with the head up and the feet up and everything, so they're just completely butt first. So, pardon me, all of those are breech presentations. And there are some issues with the mom during the pregnancy that can greatly increase the risk of a breech presentation. So we'll be talking about those. We call it limb presentation. It also would be considered a breech, but a limb presentation, you know, if you've got a limb sticking out, wouldn't that freak you out? Now I have to say I haven't seen that. In this event, you're not delivering this baby. The baby's not going to deliver this way. You're not going to deliver it. There's a chance that the physician can insert his hand in there and do some moving around of the baby, but most of the time they're just going to do a cesarean. So for us, our biggest deal is get rolling as quickly as possible to get that baby and the mom to the hospital. Now, the instructions say place the mother in a head down position, oxygen and rapid transport. I think I've got a picture here of the head down. No, where was that? Head down. And this is difficult to do while you're moving in the ambulance, where you actually put the mother on, it's like all fours, where they're going to put their head down on a pillow with the butt up in the air on their knees. That's going to release the pressure off the baby, the umbilical cord, make it easier to delay delivery in this case. But it's difficult to do. The other thing you can do is lay them down on their back and elevate the hips by putting pillows up under the hips. That's going to tilt the uterus down and the baby in a down position, so it's going to take the pressure off, hopefully. Okay. These are some of the complications of delivery. A prolapse cord. Prolapse cord is going to be when the umbilical cord is the first thing to present. So you go to check for crowning and you see the umbilical cord hanging out. That's never good. What are the problems with having the umbilical cord hanging out? What are the negatives there? It can easily get pinched off. That pressure on there can pinch that off. What else is happening is, say if it's not pinched off, the flow is continuing, what's happening there? It's getting cold, it's losing fluid also. It's kind of like, you know, you're warm in your car, but you stick your arm out the window. It's going to get very cold, and you're going to start sending cold blood back to the baby, and that's never good. Because what happens when baby gets cold? Baby becomes bradycardic. They become bradycardic, they die. Yeah. So we want to be very careful about that. We see prolapse cord most commonly in a breech birth. You know, if everything's out of position, you may get the cord presenting first. When the baby is premature, we run a risk of a prolapse cord. Multiple births, we have a greatly increased chance of prolapse cord. Also with, if you got a premature rupture of the amniotic sac or in the presence of trauma. In all these cases, it's not uncommon to have a prolapse cord. So prolapse cord, the cord's presenting first, it's hanging out, it's never a good thing. Are you going to like stick it back up in there? Nah, not going to stick it back up in there. Okay, here is, I guess that's a prolapse cord. See, one of the issues here, like John mentioned, it get pinched off. As it's hanging out, it's caught between the baby's head and the pelvis, and it's putting pressure there, so the baby's not getting any circulation. So in this event, prolapse cord is like very, very bad. So, first thing you want to do is elevate the hips. You may actually relieve that pressure. Oxygenate your mom. You want to make sure she's got as high a concentration of oxygen as possible if there's a compromised circulation to the baby. Keep the mom warm. It keeps everybody warm. Try to keep the baby's head away from the cord. Now, we don't have this x-ray vision, but if you are doing your exam, you see a prolapse cord and you see crowning, then you've got a head that's pressing on that cord. So your options are keep the baby's head away from the cord. What this means is you're going to have to, like the picture here, you're going to have to insert your gloved hand inside the vagina there and raise that head off the cord. I had a friend that actually held that off the cord for 45 minutes. He thought he was going to die, holding his hand up there. Because it's work. You're holding up, you know, what does that baby's head weigh? A lot. You know, you're holding it with a couple of fingers. So you can see that by elevating the hips, it's going to help shift some of that weight forward or superior, so to speak. But if you can get the mom turned over so that she's, you know, in the head down position, that will fix this. But it's very difficult to transport in that position. Okay, don't attempt to put the cord back in. If possible, you want to wrap this cord in a moist, but sterile if possible, clean, a moist towel, because you don't want it to evaporate. You know, you don't want it to lose fluid that way. But you wrap it in a moist towel, you still have got to keep that warm. Okay? So you're going to have to wrap it in dry towels around there. So probably what I would do, I've got a moist towel, I'm going to wrap it around there, and then if I've got some plastic or something, I'm going to cover that, and then I'm going to try to warm it. Blankets, you know, turn the heat up in the ambulance, whatever you need to do to keep that warm. And then transport the mom, but you're going to be like this, holding the baby's head off of the cord. So you don't want to get this, but this is something you can fix. I mean, you can't fix it, but you can manage it if you can hold the baby's head off the cord. Do not allow the mom to push. She may feel like she needs to push. If she delivers this baby with that cord there, we're probably going to lose the baby, and you may lose the mom too. So you do not want that to happen. Okay, other stuff about the prolapse cord. Yeah, I already just told you that. All right. This is the knee chest position. Yeah, I thought I had that in here somehow. It's difficult to transport this way, but this will move the baby. As you can see, it's going to move the baby down this way and take the pressure, the head pressure off of the cord, hopefully. Okay, multiple births. This is, you know, when you start asking that mom all those questions, when you ask about prenatal care, what'd your doctor say? What's he expecting? Triplets. Thank you for that. You know, when are you due? Last week. In a month. Okay, make sure if you suspect or they tell you it's multiple births that you've got the resources that you need. What would that be? What resources would I need? I need more people. Yes, more people. Another ambulance. You don't necessarily need an ALS ambulance, but I mean if it's multiple births and you probably got prematurity, so in that case probably do want ALS. But just for a normal delivery, you know, everything's normal, you don't need ALS. But make sure you call for backup. Make sure you got enough OB kits to get this thing done. After you deliver the first baby, you're going to go ahead and clamp that cord. You're not going to wait 5 minutes because you may have 2 babies with 2 cords hanging out. So go ahead and clamp and tie off the first baby. Get that cut so you can pass that baby off to somebody else so you can be ready for the second one. Now, you know the difference between fraternal twins and identical twins, right? Yeah. So with fraternal twins, you're going to have 2 sacs. With identical twins, probably going to have the 1 sac. But you're still going to have 2 cords. You're going to have 2 deliveries. Your treatment's going to be the same. These babies are going to be smaller, so they run a much greater risk of requiring resuscitation. Because they're smaller, they're not going to have the same amount of body fat that a full-term baby has. So keeping them warm is going to be even more important, if you can imagine it being more important. So you're going to treat each one individually, but recognize that they are at a much greater risk. So be prepared to do CPR, be prepared to bag. As soon as that mother tells you they're expecting multiples, then you're going to get all your stuff out because there's a good chance you'll be using all your stuff. Okay, ready? What is the biggest problem for a premature baby? Biggest problem you're going to have with a premature baby? Pretty good. Respiratory. Respiratory is what's going to kill these babies. The problem with preterm babies is the lungs are not fully developed. They haven't developed their surfactant, which is what helps keep them inflated. So they're very immature. So the more premature they are, the greater chances are you're going to be bagging and doing resuscitation. And it's all pretty much respiratory nature. Premature baby, you need to know this, is one that weighs less than 5.5 pounds at birth and is born before the 37th week. Is that what I told y'all? Actually, before it's going to be 36. I think I know. I thought I read that 37 is considered premature. But if it says before the 37th week, then we're talking about 36. I'm going to have to check that. But
So if it's, what was on the 37th week? Was earlier, I think. Was it older?
well, I put this, your book, what does your book say? Say 36 or 37?
37.
So before 37? Or does it, so that means 36. So that means 37 is considered term. 36 is considered preterm.
So 36 and
So-
6 days is preterm.
Yeah.
So are you saying there's a difference between term and full term?
Well, when I say term, I mean full term.
So 37 and 38 are both full term?
Yeah.
Okay.
So 36 will be preterm. And then 5.5 pounds either way, either one of these. If you've got a baby that goes 38 weeks and it weighs 4.5 pounds, somebody's made a mistake somewhere along the way probably, but they're still going to consider that premature. That makes sense? Yeah, I think early on I said 37 is premature, so make sure you make that change. 37 is going to be considered full term, 36 is going to be premature. But the book, the terminology is weird. It says before the 37th week, which means 36, right?
Why won't they
The what?
just say
I
that?
don't know. I think that's very confusing. Okay, premature, keep the baby warm, manage the airway, recognize that you may be doing ventilations and chest compressions. Watch your umbilical cord for bleeding. You know, once you clamp it off, make sure that it's clamped all the way and it's not continuing to bleed. That would never be good. You may consider blow-by oxygen on a patient. When would you just do blow-by? Heart rate. Yeah, if it's blow-by, if it's over 100, and why would you do blow-by? Yeah, if they have central cyanosis, I'm going to give them blow-by. if you've got a premature birth you have issues with, you want to call the emergency department as soon as possible so they make sure they got the incubator, they've got the neonatal team down there. Talked about meconium. If the amniotic fluid is discolored, you want to make sure you suction before that baby is stimulated. So as soon as that head delivers, you want to make sure you suction and do a good job of it before you continue delivering, because you don't want them to aspirate that. Doo-doo in the lungs is never good, right? You can imagine that. So suction in the mouth and then the nose before the body delivers. Make sure the airway remains open. Okay. Why is it important to have your partner, another person, birthing coach, observing as you help the mother through childbirth?
Catch something like
Well, I'm busy delivering the baby, right? Why is it important I have somebody else there?
Watch the mom.
Yeah, what if she throws a clot while I'm delivering the baby? Yeah. Okay, emergencies during pregnancy. Excessive pre-birth bleeding. This is where, some moms call 911. She's pregnant somewhere along the path and she starts to bleed. So preterm bleeding, ectopic pregnancies. Ectopic pregnancy is what I alluded to earlier as we started this presentation, when you actually have where the ovum implants itself in the fallopian tubes. That's an ectopic pregnancy. Very high death rate from ectopic pregnancies. So you can lose a mom very quickly. I think we're going to go into this here in a minute. Seizures during pregnancy, it's never good. Talk about that. These are ones we're getting ready to talk. Miscarriage and abortion, trauma during pregnancy, and then of course stillbirth. So these are the things we're getting ready to hit on here. Accidental death of a pregnant woman. Talk about that. Okay, excessive preterm bleeding. The mom may or may not have pain from that. She may just look down and go, man, I'm bleeding all over the place. What's going on here? And it can be due to several different things that we'll talk about still. If they've got a lot of bleeding, you want to make sure you care for shock. I mean, that's the main thing you're concerned about. If they've lost a lot of blood, you've got to manage shock. How do we care for shock? Oxygen, warm, cover them, that's warm, position them, right? High flow oxygen, transport, and then control bleeding. Okay, problems. Antepartum means pre-delivery, anti means before, right? Antepartum. Excessive bleeding, am I going the wrong way? Yeah, sorry. Okay. Things that can cause hemorrhage. They may have a spontaneous abortion. That's 20% of pregnancies, first pregnancies anyway, end in a spontaneous abortion of some sort, usually in the first few weeks of pregnancy. Oftentimes, the only sign or symptom that the woman has is just bleeding that's a little bit heavier. Oftentimes, they don't even know that they're pregnant. Just heavier period than they're used to. If it's more than a few weeks into it, they may actually pass some tissue. In that event, they may feel some contractions associated with that. Occurs in 15 and 20% of pregnancies. 50% of those are a genetic disorder. Sometimes it may be an infection, drug use, or some other disease process with the mom may lead to a spontaneous abortion. Sometimes they don't know what the cause is. It's idiopathic. Patient history, you just want to know if they've felt any cramping or if they've had a lot of bleeding associated with that. Spontaneous abortion, cramp-like abdominal pain. They may have moderate to severe bleeding. It could be bright blood or it may be dark blood. If it's dark blood, it's what? Old blood. So the miscarriage may have started and it wasn't complete. You may get old blood. They may have to actually go into the hospital to have that material cleaned out. They may pass some blood clots. If the mother has captured some of that material, you'd like to be able to transport that to the hospital. They may do some genetic testing on that, or test to see if they can find out why that occurred. If not, it's okay. Okay, let's see. Which disorder presents with painless bright red bleeding? We'll see if you happen to have the opportunity to read your chapter here. Painless bright red bleeding. See how many guesses we get here. One more. Okay. Well, I wonder if the 23% that got this right, if they knew it or if they just guessed. Placenta previa. Painless, bright red bleeding are the things that separate placenta previa from everything else. If they say that there are, in placenta previa, we're talking about a woman that's been confirmed that she's pregnant. They're several months along. Oftentimes this occurs late in pregnancy where we have placenta previa. So remember that placenta previa is painless, bright red bleeding. Okay, so if you see that. With placenta previa, can you see how is this picture different than the normal picture? That's at the bottom. That thing is at the bottom. That thing, this thing, the placenta, is supposed to be where? Here? Yeah, it's supposed to be right up here. Well, it's not. So what's happening here? Yeah, that baby is trying to engage, and all it's got is pushing its head against the placenta. So that's never a good thing. In this case, you're going to get a placental rupture, and you have, in this event, it's pretty darn serious. So with that head there, why is it going to be bright red instead of dark red? Yeah, it's right there. So as it bleeds, it's going to slide right on out. So, but this also is not real painful. The placenta itself doesn't have nerve endings to it. You know, his head pressing on here and the movement of these blood vessels, the breaking, is not going to be painful. Now, the mother could have a placenta previa and it's not really bleeding, where it's just the pressure on here, but until that ruptures, you're not going to get any bleeding. But it doesn't cause any pain. So that's placenta previa. Now this thing can attach over here. It could be such that only the little lip of it is hanging over the cervix here. In that case, you may still get some bleeding, but it's not nearly as serious as it is when it's completely obscured the vaginal opening. Placenta is misplaced and later pulls away from the uterine wall. We're talking about placenta previa. That's a different one. Placenta is misplaced. If they start bleeding a lot, you're going to treat them for shock, right? You're going to try to control bleeding. You're going to put a pad up there. That's about all you can do. The uterus is going to be soft and non-tender. There's nothing cramping going on here. This is just pressure here that's causing bleeding, and she can go into shock from blood loss. Predisposing factors. These are things that may lead to placenta previa. Multiple deliveries. The more deliveries she's had, it increases her risk of placenta previa. If she's had a lot of pregnancies in a short amount of time, you know, she's got 4 kids under the age of 4, that increases her risk of placenta previa. Older moms, older than 35, increases the risk of placenta previa. If they've had placenta previa before, increases their risk of having it again. If they've had early vaginal bleeding, that may indicate that they are developing a placenta previa. Okay, next one, and this is much more serious, abruptio placenta. This is big time bad stuff. And remember in placenta previa, his head is just pressing on that poor old placenta and squeezing it and making it bleed. Plus he can't get by it. In abruptio placenta, doesn't that sound awful? Abruptio? Abruption? That's bad. Sometimes they'll just call it an abruption. With abruptio placenta, the placenta is actually ripped away from the uterine wall. It rips away. So once that rips away, what's not happening now? Yeah, we have really compromised circulation to the fetus. So that's never good. So you can see this, if it's placed properly, and it's ripped away from the uterine wall, what's that bleeding going to be like? It may be profuse, but it's got to work its way all the way down from, up by the diaphragm. It's got to leak all the way down here until it gets out. What color might you expect? It may be darker bleeding, yeah. Now, I told you that there's not any nerve endings actually in the placenta, but there is between the uterine wall and the placenta. When this thing rips away, it's going to be like somebody pulling your arm off. No anesthesia, they just grab it and pull it. Is that going to hurt? Yeah. So this is extremely painful. It's sudden, very severe pain. Here you may look at significant blood loss, but you may not have a lot of blood down here. It's going to be gathering all through the pelvic cavity in here. Any little nook or cranny it can find, it may develop in there or pool in there. So you may not get a lot of bleeding, but it's going to be very painful. What have I got here? Bleeding between the uterus and the placenta. And you can have a complete abruption or a partial abruption. Which is worse? Complete, of course. If you get a complete abruption, you run a great risk of losing the baby. Great risk of losing the mom, too. Partial abruption really will just depend, how much of it has been ripped away. So know that abruptio placenta is extremely painful, high fatality rate. You're going to treat this mom for shock. This is going to be a rapid transport. This is going to be called ALS. They're going to have to be very quick to save this baby. Okay, predisposing factors for abruptio placenta. These are some you're already going to know. Hypertension. So if the mom has got hypertension during pregnancy, she increases her risk of abruptio placenta. Any use of drugs or vasoactive drugs, which means, if it causes vasoconstriction, then that's a bad thing. Increases the risk of abruptio placenta. Preeclampsia. We haven't talked about eclampsia and preeclampsia yet, but we will. What's multiparity? A lot of what? Yeah, is this babies or is this pregnancies? Okay. A lot of pregnancies increases that. If they've had a previous abruption, smokers, mothers that continue to smoke, run a greatly increased risk of abruptio placenta. If the umbilical cord happens to develop and it's very short, it increases that risk, of course. Premature rupture of the amniotic sac. If the sac ruptures and the fluid is lost, as that sac pulls away from the placenta, it tends to pull the placenta with that. So premature rupture of the sac will increase the risk of abruptio placenta. If we go through this and we don't come across preeclampsia, somebody remind me to talk about that. All right, y'all ready? Got a star up here. Oops. One more. Diabetics have a greatly increased risk of abruptio placenta also. Okay. Which distinguishes placenta previa from abruptio placenta?
When you say diabetes, are you talking about gestational diabetes, or are you talking about type 2 diabetes?
Both. All right, everybody answer? Yep, you did. Okay, almost, yeah. The main thing that's going to distinguish it is going to be the pain level. One is painless, the other one is extremely painful. Color of blood, and I also mentioned that with the one, you may not see any blood at all. With abruptio placenta, there may not be any blood where you can see the color, but there will always be a pain issue here, either absent or not. Okay, ruptured uterus. If the uterus itself ruptures, and this frequently is going to be due to a traumatic injury, if their uterus ruptures, that has a bad outcome also. Pathophysiology, the uterine wall, it typically thins late in pregnancy, so it's possible it can be a spontaneous thing. Trauma increases it. Maternal mortality is going to be close to 20%, fetal mortality 50%. So if you get a uterine rupture, is a real good chance you're going to lose that baby. You can see the baby's head coming through the sac there. Not good. Severe abdominal pain, nausea, vomiting, shock will be your signs and symptoms, but severe abdominal pain, watch for that. Now you're not going to probably, unless you have a lot of bleeding, you're not going to be able to differentiate this in the field from abruptio placenta. It's going to be severely painful. The blood's going to be the tip-off, but as you can see, this placenta pulls away. You'll eventually see some bleeding, probably. So that won't be an easy one for you, but when you're, if you get a question about it, you just understand the different pathophysiology. Treat for shock. Ruptured uterus, predisposing factor, if it's happened before. Abdominal trauma, very frequently the cause of this. If the baby is very large, they run a greater risk of rupturing the uterus. Subsequent pregnancies, a lot of deliveries may increase that. A prolonged labor, a very difficult labor, increases that risk. If they've had a cesarean or some type of uterine surgery, so it's weakened the wall there, you run an increased risk of a ruptured uterus. Okay, ectopic pregnancies. This is important because we do see them. Just about everybody's known somebody that's had an ectopic pregnancy. Know anybody that's had one? Women? No? Okay. I have. Anyway, as I said, this is when the ovum implants in the fallopian tube. Most of the time, 90% of the time, this is where the aberrancy occurs in the fallopian tube. But the definition of an ectopic pregnancy is any implantation outside of the uterus. So somehow, and I don't know how it happens, it can get outside the uterus, it can be in the abdomen, it can actually be fertilized and implant in the ovaries. So all those are very unusual. Most of them are in the fallopian tubes. You can imagine if this implants and starts to grow, how small is that space? Very small. So it's going to rupture this. This is extremely vascular, so you can lose a mom very easily in this way. Okay, let's look at predisposing factors. When I told you at the start of this lecture you need to be taking notes, you're going to make note cards. You just got to learn these things, the signs and symptoms, so you can recognize them. Predisposing factors, if they've had one ectopic, there's a good chance they'll have other ones. PID, we haven't talked about that yet, pelvic inflammatory disease. We're going to get to that at the end here in just a couple minutes. If they've had pelvic inflammatory disease, it greatly increases their risk of ectopic pregnancy. If they've had surgeries, if they've had a lot of gynecological problems where they've got, adhesions or scar tissue, a tubal surgery, that of course greatly increases the risk of an ectopic pregnancy. Assessing a patient. Usually it's going to be, in the beginning, it's going to be a dull, achy pain. Oftentimes these women don't know that they're pregnant. They just have abdominal pain and it's dull and achy. They're not able to really localize where that pain is. But as it develops, it's going to become very sharp pain. It's going to be very painful, like a stabbing pain. Usually it's going to be on one side of the abdomen or the other, depending on where it's implanted. They may report shoulder pain as part of that, and that's going to be a referred pain, right? As there's bleeding in the abdomen, blood is very irritating, and that's what's going to cause that shoulder pain as the blood irritates the diaphragm. Vaginal bleeding may be heavy, it may be light, they may not have any bleeding. Abdominal pain certainly may radiate to one or both shoulders. A bloated abdomen because filling up with blood in there. This is a person that's probably going to be very shocky if you get them towards the end of this. You're going to do orthostatic vital signs. You're going to get vital signs when they're laying down and vital signs when they're sitting up. That's called orthostatic vital signs. You may see discoloration around the navel, depending on when the rupture occurred. If it's ruptured and the bleeding in the abdomen, you may see a discoloration or bruising around the navel. So these are things you're going to try to look for. and I don't think we talked about it so much in the abdominal chapter, but if you've got a female of childbearing years with abdominal pain, you're going to treat it and assume that it's an ectopic pregnancy and hope that it's not. So if you've got a 25-year-old in childbearing age, she doesn't know she's pregnant yet, but she's got, a severe abdominal pain, then she's got an ectopic pregnancy until it's ruled out. Because if you overlook that, this is not a patient you want to no load. This is not somebody you want to say, go take a laxative or something. Don't do it. You want to transport them. Now ready? How about it? Just start it.
ready.
Where's your little thing? In your
Right
hand? All right. PID is a predisposing factor for let's see, who remembers? Some of you don't. You're kind of sitting, which one am I going to pick? Come on, come on. Everybody's getting tired and restless. Come on, come on. Come on, one more. Somebody sleepy? I'm moving on. Okay, some of us were awake for the most part. Good job. Antepartum seizures and blood pressure disturbances. Yeah, we're going to talk about it now. Seizures in pregnancy. We hate to see them. Seizures in pregnancy usually often indicates the existence of, that would be eclampsia. Preeclampsia, it really means pre-seizure. Once they've had a seizure, we call it eclampsia. Preeclampsia is really before a seizure. We see this when the mom is having blood pressure issues. That's why they check the women so closely during pregnancy, watching for blood pressure spikes. Once the blood pressure starts to elevate, it greatly increases their risk of seizure. We see it, besides elevated blood pressure, we see it when they have excessive weight gain. That's why they weigh them every week. If they spike and they put on 10 pounds in 1 week, a lot of that's probably going to be fluid, which is never good. And the blood pressure spikes. And you'll see a lot of edema. The face, the hands, the feet, all over increased edema. As it progresses towards eclampsia, you may see altered mental status, headache, light sensitivity. All these indicate that they are moving from preeclampsia to eclampsia. Things you're going to be looking for. If they have a blood pressure over 140/90, then they're hypertensive and they run a great risk of seizure. If they're diabetic, they have kidney disease, liver disease, heart disease, blurred vision, spots before their eyes, severe persistent headache. All of these are very high risk of seizure. So you want to start asking your mom. I don't mean your mom, your patient mom. You want to check that blood pressure. You want to know if they're diabetic. Or they have gestational diabetes. Gestational diabetes is diabetes that occurs only in the presence of pregnancy. Pathophysiology. Preeclampsia is high blood pressure and swelling of the extremities. Now, another thing they're going to do is check the urine. Once they start seeing that there's protein in the urine in the presence of increased blood pressure and edema, then they're going to call that preeclampsia. These are the women that they put in the hospital to watch them. Once they've had a seizure, then we're going to call that eclampsia. Once they've had a seizure, that's extremely bad. Some bad stuff. It's life-threatening to the mom and the baby. You're going to treat them the same as you would for any seizure patient, but just recognize that this patient may have a bad outcome. You want to transport them on the left side and recognize that it could, if they've had a seizure, it could be eclampsia, but it could be from hypoglycemia, right? So the seizure could be result of something else. What's the most common cause of seizure?
Not taking medication.
Right, non-compliance with medication. So she may have a seizure history, for whatever reason, wasn't taking her medications. So it may not be eclampsia, but we're going to treat it like it's eclampsia. PIH, terminology, pregnancy-induced hypertension. So you get some moms that if they've not been hypertensive at all, then they're pregnant, now they're having blood pressure problems. So not sure when that occurs, but pregnancy-induced hypertension, PIH, 140/90 is considered hypertension in any patient, not just pregnant patients. But they'll monitor that blood pressure. If they come in once and it's 140/90, they're going to put them on notice. If it happens again, then that's when they're going to start talking about hospitalizing somebody. If they got edema and protein in the urine, it's going to be preeclampsia. Your care is going to be treat them very carefully, transport them quietly. You don't want anything that's going to get them excited, anything that's going to get their blood pressure up, anything that's going to freak them out. You increase the risk for seizure. Okay, y'all ready? Trying to keep you guys awake here at the end. Placenta, fluid, and fetus weighs together about all right, one more. Somebody's sleeping on the job. Okay. All right, well, about 20 to 24 pounds. You know, she may put on a little bit more fluid or weight in other areas, but the baby, the placenta, the fluid inside the uterus all is about 20 to 24 pounds. Okay, supine hypotensive syndrome. We talked about this early on in the semester. When you consider the weight of the uterus, you're talking about 25 pounds. If mom lays flat on her back and she's got that big old glob like laying right on her stomach flat, you run the risk of compressing the vena cava. Once that happens, you're interfering with blood flow, you know, back from the extremities, from the lower part of the body. So that may cause a greatly decreased cardiac output, which then is going to put your mom at risk. Her blood pressure is going to drop. You may get altered LOC. She gets dizzy, that kind of stuff. So you want to prevent this. How are we going to prevent this? Yeah, don't lay them flat. Just tilt them over just a little bit. Remember we talked about that earlier? Just a couple of inches will do. You don't have to like turn them up on their side, but you know, just take a little bit of that pressure so you displace the uterus a little bit to the left. Mom's going to feel dizzy and lightheaded, blood pressure drops. So just keep that in the back of your mind. You know, you've got her laying down, you forgot to tip her off the side a little bit. Okay, trauma. Trauma in pregnancy. For some reason, domestic abuse increases greatly during pregnancy. Maybe it's just the stress of having another mouth to feed or whatever, I don't know. But we see a greatly increased domestic abuse issues with pregnant women. Their pulse typically is going to be increased 10 or 15 times per minute right over a non-pregnant woman. So you're going to be looking for even more tachycardia. You know, if they're at 140 or something, 130, whatever, you know you've got a problem. They can lose a lot of blood before they become symptomatic. They can lose 30 to 35% of their circulating blood volume before they start looking shocking. So bottom line here is you're going to treat for the worst and hope for the best. Any kind of trauma, you know, where they got bruising or not, this is a patient that's involved in a fender bender, or maybe a little bit more than a fender bender, and the airbag goes off. I don't hurt anywhere. I'm all good. Everything's fine. Not much damage here. You're going to transport that patient in the last of pregnancy? You bet. Because if they've had any type of disruption, you know, in the uterus, the placenta, they start to bleed, you can have a problem. But they're going to compensate because their body's been compensating for 9 months now. So they're going to compensate longer. You want to ask her, have you been hit in the stomach at all? Have you been hit in the abdomen? You know, did you fall? Did you hit anything? You need to know if that trauma may have occurred. Because as we've talked about, ruptured uterus you see frequently with traumatic injuries to the abdomen. So what do we say? What's the mortality rate for babies in this? 50%. So it's a big deal. All right, what if the mom dies? Say she's been in an accident and the mom passes away. How are you going to best preserve the baby? Do what? Yeah. You're going to do doing the best for your mom is going to provide the best for the baby. So CPR, ventilating your mom, is going to be your best chance to save the unborn child. Begin CPR immediately. Continue CPR all the way to the hospital. It's a good chance you've given enough blood flow to the baby that the baby can survive. So ordinarily, if you've done CPR for 15 minutes in the field, 20 minutes in the field, you're probably going to discontinue CPR. If you're transporting the mom to the hospital, you're going to be doing CPR the whole way and let them manage it there. Oops. What should you do if the 9-month pregnant woman dies? Let's see if y'all learn anything. Anybody else? We only lost one person there, didn't we? Okay. Hey, good. Somebody was awake.
I feel like the last three of those are pretty important.
Oh, the last 3
One of
slides?
them's definitely the best answer. Then I'm saying the last 3 answers, transport and call for hospital help.
Yeah, but if you don't start CPR, nothing else matters.
Well, that's what I said is the best answer.
Yeah, best answer. And we'll talk about best answer a little bit later. Stillbirths, you know, this can be very difficult for you. Now, stop me if I already talked about this. Did I talk about this earlier in the semester? If the baby's born, you're going to have to make a decision sometimes whether you're going to do a resuscitation or not. If you've got a full-term baby that's born and not breathing, doesn't have a pulse, you're going to do CPR on them. You're going to do everything you can. If you get a stillbirth of, say, a baby that was 6 months gestation or 7 months, you may have to make that decision about whether you're going to do a resuscitation or not. And what I usually tell students is, because I've delivered several very premature stillborns, when you look at that fetus, that baby, if they don't have an opening in the nose or the mouth, you can't ventilate that. You know, they're going to have to be a certain stage of development where those open up. So once their nose and mouth holes are open, then you can bag them. So in that event, I'm probably going to do a resuscitation unless it's obvious that the baby's dead. You know, you will know that the baby has been dead for a while. You know, the skin starts sloughing off, the material sloughs off, they're going to look cyanotic. They just are, it's obvious. But if it's not obvious that they've been dead for a while and they've got openings here, for you and for the mom, any family members, you want to go ahead and do a resuscitation. You know, just bag them, ventilate and do CPR to the
How long?
hospital.
Oh, okay.
Yeah, and then let them sort it out. You know, babies that are real premature in the field don't have a real good chance because we don't have incubators. You know, we don't have all the stuff to manage a newborn that's very premature in the field. You know, in a hospital environment, you know, they've saved them, you know, 22, 24 weeks. That's not going to happen in the field. In the field, to have success, you're probably looking at 28 weeks or later. It's going to depend on how far your transport is, how close you are, what the facilities are like. You know, if you're just outside, you know, Birmingham, close to Children's Hospital with a really good neonatal unit, fine. If you're like right here, delivering at, you know, 26 weeks and your closest hospital is up here, I don't know what they have there, but I don't expect them to have a whole lot. So anyway, you may have to make this decision about whether or not you're going to do resuscitation. If they're not obviously have been dead for some length of time and they've got a mouth and a nose hole, then then go ahead and do it. If they are born and they just happen to be in respiratory arrest or cardiac arrest, usually that happens right at the birth. You know, as they're squeezing out, the heart stops. Usually it's because of the respiratory. I told you as that squeezing occurs, part of that, you know, is so they can start breathing, but it stops them breathing so they can start breathing again. So sometimes as they come through, they don't start breathing again, and that's when we are going to stimulate them. So you may have to do CPR on the baby. If they're all normal-like, they're fully developed, then you have a really good chance of, you know, saving that child if you'll just get right on it. If the baby is dead, you're not going to resuscitate, then you're going to be there for emotional support. You know, it's a very difficult time for the moms There are times where they know the baby's already died in utero and they want to wait and have them deliver normally in some instances. So you may actually be the person doing that, and that's never good either. Let's talk about pulmonary embolism. As I told you, a pregnant woman, particularly near delivery and after delivery, they're at an increased risk of pulmonary embolism. And that can remain for several weeks after delivery. You know, as the body's readjusting and the clotting factor backs off. Pulmonary embolism is responsible for 20% of maternal deaths. But we don't lose that many pregnant women during delivery. So 20% sounds like a lot, but we don't lose that many. But 20 of the ones we do, 20% of them is due to pulmonary embolism. We have coagulation issues here. The body acts to form clots. We also have increased blood volume there. We know the signs and symptoms of pulmonary embolism, right? It's the same for everybody. Shortness of breath. They may get shocky, sharp chest pain. Care, it's going to be ABCs. Treat for shock, you may have to bag it. Depending on where it's lodged, how big it is, will depend on whether you're going to have a chance or not. Okay, gynecological emergencies. We'll get through these fairly quick. Somebody know how close we are to the end?
Very close.
I know y'all are dying.
Yeah.
Vaginal bleeding is bleeding, right? We're going to treat bleeding. It's going to be bleeding and shock. We're going to treat it just like that. Watch out for hypovolemic shock. There's not a lot you can do about it other than treat for shock. Trauma to the external genitalia. You want to know what the mechanism of injury was. You're going to treat for blood loss. You're going to treat for shock. Also look for any other injuries, other internal injuries. You know, you're going to palpate the abdomen. You're going to get some history here. See what's going on.
If you're in like a car accident and the mom's dead.
The mom's dead, is that what you said?
Yeah. Can you like cut her open and give her the
No. No.
But sometimes it might save the, you know.
There was a case in Florida when I was working down there, in fact, of that very thing. The crew responded to, I can't remember what the cause, it seems like it was some kind of trauma, and the paramedics were at bedside when the mom died.
Mm-hmm.
She was 9 months pregnant. I think she was in labor. I can't remember if she threw a clot or somebody beat her. I just can't remember. It was way the heck out in the sticks. And they called med control, and the physician talked them through doing a cesarean. Don't ever do that. If you guys are going to grow up and be physicians, don't do that. Talked them through. The baby was born. The baby was severely handicapped after that. You know, had brain damage. You know, had been some time before they actually got the baby out and whatnot. So the family sued. The mom died. The family sued for support because the baby should have died with the mom. And had they been acting within their scope of practice, it wouldn't, you know, the baby would have passed away. They did something that was not in their scope of practice. You know, they did save the baby, but the baby had, you know, was going to have to be on full support its whole
So they
life.
lost their job.
It was bad.
But
Yeah.
sometimes they actually might not be her. Like, you know, the baby might not. Oh, I
Yeah,
know
it's
about the
way
mom,
it's
though.
way out of your scope of practice. I wouldn't even go on that one. I just don't think I'd go there. But that's a tough one.
You know,
But-
like if I was like the dead mother, you know, I like the last thing would be like save my baby, you know.
yeah, that's a tough one.
Yeah, I won't.
There was another one similar to that, also in Florida, where some guy was ejected in a high-speed crash on I-10, close to Tallahassee, and some passerby stopped. He saw the wreck. He was a paramedic from Tennessee. He pulled over. He happened to have a jump bag with a bunch of stuff in there, so he ran over there, you know, got the guy, whatever he was, and he intubated him, and they did CPR, and he was transported to the hospital. Well, he survived, but he was a total vegetable. The family sued, and they won that one too, because the guy, number one, he was from out of state, so he wasn't licensed in the state. Shouldn't have been carrying any ALS equipment. So guys, you don't ever carry any ALS equipment. If you want to carry a bag valve mask and some 2x4s, that's fine, but you don't need to be carrying anything else. Some gloves.
That's just messed up.
I don't understand that.
Do what?
That's messed up with the family
He was trying to
insurance
help.
cases, just, yeah.
Well, you know, it's possible they don't have any insurance. You know, they're having to pay to
But
keep
it
this.
still doesn't make it okay to be a charitable person. Like, money shouldn't excuse any acts that's bad.
Oh my gosh.
Honestly,
It's the
Probably
legal
causes
system.
Probably 90% of problems in the world.
Oh, that's.
Well, there's a lot of them. So let's move on to sexual assault. This is a problem too. You want to treat any immediate life threats. You know, our job is not to catch the guy or the female. It's not to, you know, be law enforcement. Our job is to provide patient care for the patient. Don't disturb any evidence if you can keep from doing it. Some of those things include, you know, you don't want them to go and wash up. If you've got particularly a woman that's been violated, she wants to take a shower. She wants to be clean. You know, she wants to change clothes. And all that's got evidence. So you want to try to prevent them from doing that. You don't want them to go wash. So try to preserve the evidence whenever possible. Examine the genitals only to see if there's severe bleeding. Otherwise, you don't need to be down there. You may be disturbing evidence. So you're just treating any external bleeding there. You have to report that. So that's like a no-brainer, isn't it? All right. When arriving at a crime scene, what are the key things to keep in mind as you respond? Your personal safety, scene safety, certainly. Do what? Preserve evidence. But your main responsibility is going to be what? Patient care. Yeah. And that's something, sometimes you do run into some issues with law enforcement because they want to catch the bad guy. They don't want you to mess up any of their evidence, but you need to treat the patient. So, all right, let's see. Get through this. What's the difference between abruptio placenta and placenta previa? Abruptio placenta, which one's worse? Abruptio. Which one is going to be painless? Placenta previa. Which is bright red? Placenta previa. Which has the higher mortality rate? Okay, good. Didn't I say that right? Mortality? Die?
No, that would be fatality. Mortality is a preview. They're the same thing.
Mortality.
Mortality is living.
If I have a mortal wound, I'm dead from
Okay,
it.
yeah, not mortal.
Okay.
Mortal is okay. Never mind.
All right.
I'm not on that thing.
I know, it's late for everybody. Okay, I already said that. All right.
Mortal is a living person.
How do you care for a prolapsed cord?
You need to like put
Keep
moist.
the baby's head off of it.
Okay, keep the baby's head off of it. How are we going to care for the cord?
A moist.
Moist and warm. Don't let the mom push. Knee chest position. Rapid transport. What do you do if the bag of water is still intact during delivery? Yep, pinch it. What do you do if you have a nuchal cord?
Needed scissors.
Yep, try to slide your fingers under and see if you can slide it off. What if you can't get it off? Got to clamp and cut. All right, you're called to a pregnant woman in labor. During your evaluation, you find that it's the woman's first pregnancy, the baby's not crowning, and the contractions are 6 minutes apart. You ask your mom if she needs to move her bowels, and she says no. That's always good, isn't it? Yeah. If she feels like she's got to move her bowels, you want her to what? Go to the bathroom? No. Because what'll happen? That baby's going to be in the toilet, you know, and down the sewer line in no time. Okay. Do you prepare for delivery at the scene, or do you transport this mother? Yeah. This one's, we're transporting this one.
No.
That was the quickest review we've ever had.
Well, wasn't. Okay, on Tuesday, we're doing one chapter. It's pediatrics. So make sure you read that chapter. I don't think it'll be as long as this one. But Wednesday, we're going to deliver babies, so y'all be ready. And Thursday is going to be your test. So that means you got to study this weekend. You're not going to have the weekend to study. Yeah, let's collect these guys. Did I get the sign-in sheet back? I'm sorry?
Trauma assessment too.
Trauma assessment on Wednesday. If you're ready to take off on medical, well, thank you. We're going to do that too.
As basics, are we going to come and talk to us about
Are we going to what?
Does Dr. Singh come talk to us about EKGs and
Uh-uh. Thank goodness.
Well, I was hoping he would, so that I could ask him if I could shadow.
You can ask him anyway.
Yeah.
Yeah, just tell him you're in our program. He's our medical director. Yeah.
The garbage is out of the garbage. How did that happen?
What?
I'm surprised you just had it everywhere.
Oh,
How did they do
brother.
that? They were all in there.
knew this would be long.
Here's my thingy.
Oh, good thingy.
And I just brought you one anyways.
Oh, if you want to give it to
Yes.
me anyway.
And I'll take this down to her. And what do we do about my trying to get in that thing, the registry thing?
You know what? Let's do this right this second. I should. You'll remind me to ask.
Isn't that weird? Like, I don't even.
Have you registered to take your registry? Done your profile?
It like gives you a whole bunch of options at the very beginning before you create your account for what you're gonna be. So I picked what I was in now, and I think it thinks that I'm already that. I don't know.
You set up your.
Yeah, I have a username and password.
Okay.
I can tell you.
I'll have to work through this thing. 'Cause I know we've done it a million times.
You can log into mine and see what's
Oh yeah,
going
we're
on.
logging into yours
Okay.
for sure.
I know you won't get in there and mess around.
You're gonna be doing it. I'm just gonna help you. Okay. Hello.
It came up just a second
Where'd it
ago.
go then?
Yeah, as long as it don't get recorded on that thing. That would be obvious embarrassment.
It came up. You saw it.
Yeah, for just a brief moment. But you know
Oh,
your
it did.
computer.
Oh no.
There it went and off. Try it in Chrome.
Look what I forgot.
Uh-oh.
I wonder if that's the problem. It's turned off.
Alright, I'm gone. I gotta go cook supper.
Oh, I'm starving.
I am too. I have no